Good evening, sir.
Hey, no problem.
Good evening, Dr. Mallikarjun, Dr. George, Kaso. How are you?
Good, dear. All well?
Yeah, yes, sir.
How are you keeping so many programs, man? You are well prepared and we are rushing up for up and down.
So, how are things in Hyderabad, sir? Everything is good?
Everything is okay, dear. Going on. I just thought I'll share my.
Yeah, please, sir.
I'll just one. I just wanted to check the. Shall I share it, dear?
Yeah, please.
Just wanted to check my.
Yeah, please share.
Video.
Yeah.
Are you able to see that? You're getting it, right?
Yes, sir. We can see, sir.
Video is. I just wanted to see the video.
Yeah.
Okay.
Yeah, video is playing. Okay. Sir. So, Dr. Malik, you can see the video quality?
Hello?
From my side, it's okay.
You're able to see?
Yes, sir.
Okay.
We can see.
Okay. So I'll skip it now. Stop, and I'll check the next video, which is left-sided.
Good evening, Dr. Gupta, sir.
ठीक है अनूप?
Yes, sir. हाँ, ये दिख रहा है. ठीक है, sir. It's running good, sir.
ठीक है. Right, I'll stop sharing that. Okay.
So I will also just share my video and see how it is running. Can you see now, sir?
Yeah.
Okay, so I just play my small video and see how it looks like there. Can you see, sir?
Good. Very nice.
Quality is okay. Okay.
Very nice.
I think okay, then I can now stop sharing. So good evening, Dr. Gupta, sir.
Good evening to all.
Thank you, sir.
Sir,
Thank
good
you,
evening, sir.
So how are you, Mallikarjun?
Sir, ठीक है sir. दुआ है sir आपकी. Blessings.
Yeah.
So Dr. Nayak, you can also share. If you want to share your presentation, you can share now.
Okay.
Yeah.
Can you see it, sir?
Yeah. So do you have any video or just presentation?
Yeah, I had some short clips. I'll just.
You can run that. Okay. Yeah,
Can you see it?
Yeah, it's running. Okay. Yeah.
Okay. Thank you.
So
तो तब तक हम पेशेंट देखते हैं 5 मिनट
सर दिल्ली का क्या हाल है सर?
Hello. Yes.
दिल्ली का क्या हाल है सर?
Delhi, we are having extreme cold now here.
कोविड
And
कैसा है सर?
yesterday the temperature was 3.5 degrees centigrade.
ओह, कोविड
Tonight.
कैसा है सर? कोविड
Trying our winter.
COVID is better, sir.
Too early winter for us, but we are enjoying it.
गुड
Only one thing is good. There's a bright sun in the daytime,
वेरी नाइस
and fog is not there as much. So that's a plus point for us
Very
actually
nice,
at the moment. So only we are waiting or praying that there should not be a fog. Otherwise, then life becomes miserable, you know, here in Delhi.
फॉग तो बनेगा सर.
No, not necessary. Things have changed.
नहीं सर, पंजाब का फार्मर तो पूरे दिल्ली में है सर. अभी तो फॉग कहाँ से बैठेगा सर?
That's why there is no fog. They are here at the moment.
वहाँ तो जलाने के लिए कोई है ना चले सर.
Rally तो जला चुके ना. That was already over now, you know. Now they are started putting the new crop. So
I
that
know.
Rally thing is over. So how is your election thing is going on?
इलेक्शन तो चालू है सर.
चालू है. So
हाँ, sir.
when is the voting dates?
10 to 20th सर, January.
10 to 20th January. Okay. Are you going to send any official communication
It's already on
along
सर.
with the biodata of the candidates?
वो सर वो सब आने वाली सर. अभी इस
So
वीकेंड
because we are receiving a lot of this you have allowed officially now. for
Yes,
canvassing. So we are getting a lot of email and WhatsApp message and everything.
वो तो 2 साल से चालू है सर.
And like politicians, what they will do in 1 year, that's very interesting to know. So even I have put some questions to them.
अच्छा, गड़बड़ चालू कर दी आपने. और छोड़ दे रहा था सब बच्चों को. क्या आप अपना क्वेश्चन डाले तो सब लोग डिप्रेशन में आ जाएंगे. क्यों टेंशन कर रहे हो?
लिखा कि I want to do something for the elderly. So some word was used. So I asked him kindly elaborate. What are your plans for the elderly urologist?
करते करते you will become elderly.
So
Good morning, Dr. George. कैसे हो? How are you?
Don't withdraw it now, but you should.
Please unmute
No,
yourself.
no. I think Rajiv is going to circulate the candidates this thing in the next newsletter, sir. I think this
I think so. In future also, this conversing should not be allowed. Instead
No,
of
sir.
that, there should be official communication from USIS. We have decided to.
बस 5 मिनट में हमारी
It is happening, sir. So abhi to you can't prevent it because it has already been decided. We can't go one.
So, sir, I think I will request Dr. George to please share his presentation.
Yes.
We can see whether it's running okay or not. You can share, sir, Dr. George. And you can unmute yourself. And welcome, Dr. Hoffner, sir. How are you? Good morning.
Anand sir, namaskar.
Yeah. So we can see your slides, Dr. George. Yeah. So you can run a video if you want to show the video. Just we want to see it's running okay.
T'as testé le micro, ça marche quand tu parles? Je sais pas.
Okay.
Je suis où, voilà. Toi, t'es là, t'es ici. Voilà.
John, good evening, good afternoon to you.
Yes, good afternoon.
How are you?
How are you?
I'm
Fine,
good.
thank you. Very well, thank you.
Hello, Dr. Hoffner, how are you?
Yeah, fine, thank you. Le son est un peu fort. C'est un peu fort?
So I think, sir, we can start. We have just less than 1 minute. So we'll start dot at 6 o'clock. So Manjeet, please make sure you start us live at 6 p.m. You let us know when it is live, we can start. Manjeet, is it live now? Okay, so I think we are live now, sir. So good evening everyone, and good morning and good afternoon as per the different time zones from different part of the world. So continuing with our efforts to discuss various topics, today we are discussing the international masterclass on minimally invasive adrenalectomies. And today for this program, we have three stalwarts international faculties and our all national stalwart faculties. And we have Dr. Hoffner. He's a very renowned robotic and laparoscopic uro-oncologist from Bordeaux, France. Dr. George Casso, again a renowned robotic uro-oncologist from Miami. And we have Dr. Rafael. He will be joining us shortly from Brazil. And then we have all one of our Dronacharya, Dr. Professor N.P. Gupta, sir, who will be starting this conference with his remarks. And then we have the special invitees from our USI, our President and Secretary, Dr. Anup Kumar, sir, and Dr. Rajiv TP, sir, along with the other dignitaries and other faculties. So I will first request Professor N.P. Gupta, sir. He is the chairman of Department of Urology, Robotics, Renal Transplant from Medanta, and he is our ex-USI president, and he has held many positions. He doesn't need any introduction in this gathering, but just to formally introduce, I've told that he has been awarded with the prestigious Padam Shri Award, and he was also the past president of Asian Urological Association, and he has received several orations and prizes in his illustrious career. So I will request Professor N.P. Gupta, sir, who has been my teacher and mentor, to please give his welcome address.
Thank you, Dr. Anup Kumar and North Zone USI for your invitation to join for this webinar, which is an important topic of the progress which we like to see in minimally invasive adrenalectomy. This reminds me back to 1975 when I joined All India Institute of Medical Sciences, New Delhi. My professor and mentor, Dr. Sarinder Mansingh, was very fond of adrenal surgery at that time, and he has the largest experience in the country of doing adrenalectomy operation. When we were residents and young faculty members, we remember that it used to be a nightmare both for the surgeon as well as for the anesthesiologist to see a successful completion of the surgery, because there can be a mishap at any level and there can be a catastrophe also. There has to be, I have seen also the time when it was a nightmare for a correct diagnosis, what kind of disease in the adrenal gland. And thanks to all our latest biochemical investigations and now radiological imaging by CT scan, by MRI, so more or less accurately we can come to a diagnosis. The whole scenario has changed after the arrival of the minimal invasive surgery, first laparoscopy and then robotic. Now, in the experts' hands, it has become a very routine surgery. What we see now, we don't care whether there is a adrenalectomy in the theater or this or not. And previously, everybody was concentrated to have a successful outcome. So I think so this change is a very dramatic change. It was very welcome, and obviously the technology means the laparoscopy and robotics, they are wonderful for the deeply seated small organ. Like prostate is one, and I consider the next one is adrenal gland, for which we have to make a very large incision, sometimes transperitoneal, sometimes transthoracic, and all that for the approach. But now the total scenario has changed, and nowadays even some centers are doing robotic or laparoscopic adrenalectomy as a daycare procedure also. So I am happy to see that this topic has been chosen, and I welcome all the national and our international faculty for this webinar, and let us see what advances have been in this field of the minimally invasive adrenalectomy surgery. Thank you very much and welcome you all.
Thank you very much, Professor Gupta, sir. Now we'll request our President of USI, Professor Anant Kumar, sir, to give his welcome address. He doesn't need any introduction to this gathering. He is again a chairman of Department of Urology, Robotics, Renal Transplant in Max Saket, and has been the ex-head of the department from SGPGI Lucknow. So Dr. Anup Kumar sir, please give your welcome address.
Good evening to all my friends, and good morning to my, and good afternoon to my international faculty from Europe and USA and Brazil. I welcome Dr. Hoffner. We have and we have seen him operating number of times, and he's a wonderful surgeon. I also welcome Dr. George and Rafael Cialo from Brazil. As Dr. Gupta has already said that adrenal surgery, I remember same way what he said, and now it has become a routine surgery, and even the perioperative management has become, because everything is diagnosed preoperatively, managed preoperatively, and done very well. And guideline has also come out how to, when to do minimally invasive surgery, when not to do minimally invasive surgery, and if you are doing for malignancy, then what extra you should do it. So all these things have become very simpler, and it has become a routine surgery, but still, especially the right side, if the surgeon is not careful, there may be a problem, and we have seen problem happening when surgeon was not very careful is handling, especially the right side. So I'm sure this webinar will be very helpful to all the members of North Zone and Urology Society of India, because we are going to discuss its anatomy, all the important perioperative management. We're also going to discuss the stalwarts, will be showing the transperitoneal, retroperitoneal, robotic adrenalectomy. See all of them doing a wonderful operation, and very safe operation in various workshops, which was happening very frequently in our country, but because of pandemic, we are now doing same thing virtually, and so this will be a very useful for all of us, and I hope all the members will pick up various things. And even if we do this operation very frequently, we are also going to learn, because we always learn from each other. So I thank Dr. Anup for bringing this wonderful concept, National Masterclass. And at the same time, as a president of Urology Society of India, I wish good health and safety of all my members, their loved ones and their families. Please take care of yourself, stay safe. We are all waiting for the vaccines to come, and so that we can become immune to this virus and start coming back to the normal life and have the physical meeting, which we all are missing it. So thank you very much. With this, I would welcome you again for this workshop, and back to Dr. Anup. Thank you.
Thank you, sir. Thank you for your kind words. Now we'll request Honorary Secretary USI, Dr. Rajiv TP, so please give his opening remarks. Rajiv TP.
Greetings from Urological Society of India. Good evening, everyone, and good morning and good afternoon to the international viewers. It's a great initiative by the Department of Urology, Safdarjung Hospital, and North Zone Chapter Urological Society of India to have this program, an international masterclass on minimally invasive adrenalectomies. It will be very interesting to listen to the international experts as well as the national experts who will be speaking on various aspects of minimally invasive adrenalectomies. And it will be a great thing for the as well to have a big forum of experts on adrenalectomies. I welcome all of the faculties and the viewers to this program. And on behalf of the USI, I wish this program a great success. Thank you all.
Thank you very much, Dr. Rajiv TP, sir. So we are going to start our first presentation. I just want to inform we are showing it live on various digital platforms. including our Ministry of Health and Family Welfare online education program, which is shown to 52 colleges across the country, along with the other countries. So we are going to start with the first presentation, and Dr. Brish Bhanu Nayak, he's Associate Professor in Department of Urology, All India Institute of Medical Sciences, New Delhi. He will be talking about very important topic, applied anatomy of adrenal glands. So over to Dr. Brish Bhanu Nayak.
Good evening. At the outset, I'd like to thank Dr. Anup Gupta for giving me this opportunity to speak on this international masterclass on minimally invasive adrenalectomy. So the topic that I have been given to speak is the anatomy of the adrenal gland. So before the other speakers actually come on and discuss various minimally invasive methods of adrenalectomy, I'll have to just give a brief view of the adrenal gland. So I have nothing to disclose for this particular presentation. So adrenal glands, these are actually paired organs which are located or situated on the superior pole of both the kidneys and enclosed within the gyrotage fascia. If you can see on both the sides, these are the adrenal gland. This is on the right side and this is on the left side. So they are located superior on the superior pole of the kidneys, and these are usually enclosed within the gyrotage fascia. The adrenal glands, if you look laparoscopically or maybe naked eye, it looks yellow in color. The size of the gland varies from 4 to 6 centimeters in length, and the width is 2 to 3 centimeters, with an approximate weight of 2 to 6 grams. The outer part of the adrenal is called as the cortex, and the inner part is called as medulla. So if you look on the imaging, if you see on the left side of the image, the adrenal glands looks like this on the CT scan. And on the right side also, if you can see both the limbs, this is the way the normal adrenal looks if you see it in the CT scan. These are the both limbs, lateral and medial limb of the adrenal gland. Again, here you can see both the limbs, and on the right side, you see if there is an adrenal nodule, you can see the adrenal nodule looks like this on the conventional CT imaging. So before I talk on the relationship of the adrenal gland with the other structures, which actually I would like to, it's better actually those particular relations actually been seen on a live video. That will be more easily, the anatomy can be easily delineated on a live video. So before that, I would like to speak something on the vascular anatomy. The adrenal gland, the arterial supply is by 3 adrenal arteries. The superior part of the adrenal gland is supplied by the superior adrenal arteries, which are usually the branch of inferior phrenic artery, but occasionally it can come directly from the abdominal aorta or intercostal arteries. And the middle part of the adrenal gland is supplied by directly from the branch of the abdominal aorta, and it can occasionally come directly also from the inferior phrenic artery. And the inferior adrenal artery, it comes directly from the superior aspect of the ipsilateral adrenal artery. And all these 3 adrenal arteries, before they supply the adrenal gland, they divide into multiple small branches, and then around 10 to 50 smaller branches, and then they penetrate the adrenal gland. So regarding the venous drainage, the right side adrenal gland, if you see it here on the right side, the adrenal gland is smaller in size, it's short in size, and it drains directly into the lateral aspect of the IVC. Similarly, the left adrenal vein, which is usually has a longer course, it drains directly into the cranial aspect of the left renal vein, and during the course, it also, the inferior phrenic vein also drains into the left side adrenal vein. So now coming to the important surgical landmarks. On the right side adrenal gland, if you look at the right adrenal gland, anterior laterally, the liver is located anterior lateral to the right adrenal gland, and the anterior medially, you can see the duodenum is there, and the inferior relation is by the superior pole of the right kidney, and the medial relation is with the inferior vena cava. And the posteriorly, the Schwarz major is located, and you can better see this small video clip. Here the peritoneum is getting actually, we're reflecting the peritoneum, and here you can see the liver. It's on the anterior aspect of the adrenal gland. And here we are exposing the inferior vena cava, which is forming the medial border of the adrenal gland. This is the inferior vena cava, you can see it here, which is forming the medial border. And now it is getting, we are getting it separated from the on the surface of the liver, which is actually forming the anterior relations of the adrenal gland. And these are the small veins that we're getting it separated from the adrenal gland. We're clipping those veins. This is the main adrenal, right adrenal vein. You can see the short course of the adrenal vein, which is directly draining into the inferior vena cava. Okay, then on the left side, also similarly, the left adrenal gland, the splenic vessels and the spleen forms the anterolateral relations with the adrenal gland, and the anteromedial relation is by the body of the pancreas. You can see it here. And the lateral relation of the adrenal gland is by the kidneys, and the medially it is the abdominal aorta that is located medially. The posteriorly again the psoas muscle, and inferior the renal hilum forms the inferior border of the left adrenal gland. And again I would like to show another small video clips to depict these relations. Here you can see the spleen, and we are reflecting the peritoneum, and this is the left side pheochromocytoma. Here the renal hilum, which is actually forming the inferior border of the left adrenal lesion. And on the medial surface, this is medial border, that is a spleen and tail of the pancreas. Here you can see in the inferior border, that is the left renal vein, and we're now dissecting the left adrenal vein. This is the left renal artery. This is the left renal vein. We are separating the left renal artery and left renal vein from the mass. You can see now the renal artery and the left renal vein, which is forming the inferior border of the left adrenal gland. And thank you all for your attention, and my sincere apology to Dr. Mallikarjun sir. I actually have tried to encroach into part of your topic, which is actually transperitoneal laparoscopic adrenalectomy, but I could not have done a better job without showing the video to depict the relations. Thank you.
Thank you very much, Dr. Nayak. That was an excellent presentation, and I will request Professor Gupta sir to please give his comments. This is a very important basic topic to our youngsters who are watching this webcast. So, Dr. Gupta sir.
No, thank you, Dr. Nayak, for giving the detailed anatomy of both side right and the left adrenal gland. I think so it is very important to know the anatomy, and with the recent imaging, three-dimensional, we can plan out the complete surgery beforehand to know how many vessels we are going to come across. And if we are careful, then the surgery goes on very smoothly. Thank you very much, Dr. Bhanu.
Okay, thank you very much, sir. Now we'll move to the next very important topic, a perioperative management of pheochromocytoma. We all know this is a very, very important management part, especially for a urologist, because it involves multi specialties coordination. And we have Dr. Raghavan. He's again a very senior uro-oncologist from Chennai. He's a very, very good speaker, and it's always a treat to watch him speak. So I will request Dr. Raghavan to please present this topic.
Respected teachers, Professor Gupta, Anup sir, and all the international faculty, it's an absolute pleasure to be here. I hope all of you can hear and see me.
Yeah, please continue. Yes.
So just jump into the topic, perioperative management of pheochromocytoma. It can be an exam question for all the exam going students, and it is an essential topic for somebody who does adrenal surgery. As NP Gupta sir said, in 1970s, the mortality of adrenal surgery was very high, but it has drastically reduced now thanks to our better understanding of the physiology, especially with the pheochromocytoma or any secreting tumor for that matter. In pheochromocytoma, catecholamine is released during pre and intraoperative manipulation, and there is a huge hazardous blood pressure elevation leading to cardiac arrhythmias. So it's essential that all patients with pheo is adequately prepared before they come to the theater. On average, any patient who comes with pheo first goes to an endocrinologist, who then evaluates and says that this is pheochromocytoma. The patient then goes to a cardiac evaluation to exclude cardiomyopathy and make sure that optimization is done. The base level blood tests are done to make sure that he is okay. Very, very important to make sure he is not a diabetic, and if he's a diabetic, make sure that adequate control is made for that as well. Cardiac involvement in pheo is very high, and hence a cardiologist has to be actively involved in the care of the pheo patient. I tend to advise patients over 2 weeks. It's a 2-week program. 2 weeks before they start on alpha blockade, then a beta blockade is introduced, and then there is, if necessary, fine tuning is done with catecholamine synthesis inhibitors or calcium channel blockade, and then take forward during an intraop and postoperative management. The preoperative preparation as the first line is usually alpha blockers. The second line is beta blockers or calcium channel or combination of many, and the last is the methyl paratyrosine. I should confess that I actively manage these patients alongside the endocrinologist. Usually, one Dr. N.K. Narayanan is the one who does it for me, and both of us confer. Just now we discussed and we realized that we have not used methyl paratyrosine at all in India compared to a couple of times which was used in UK. So the preoperative blockade starts 14 days before the operation. That gives adequate time for the expansion of the ECF. The phenoxybenzamine is the drug of choice. It binds to alpha receptors, especially to alpha-1. It's a reversal of drug only. The reversal of the drug is possible only through formation of new receptors. This has to be kept in mind, because in the postoperative period, when the patient goes into a serious hypotension, trying to give more and more adrenaline and noradrenaline will not help him. We have to go for vasopressin rather than for these things, because it inhibits the alpha receptors permanently. The patients are given salt load enough to increase the ECF volume. Problem is postural hypotension and reflex tachycardia that has to be patiently titrated. As I said, we start 14 days before the surgery, 10 milligram twice a day. It can be increased to as high as 70 milligram per day, but usually in our experience about 30 to 40 milligram is sufficient per day to achieve adequate target BP for them. The last dose is given the night before surgery, and the morning of the surgery no dose is given. And also keep in mind, pheochromocytomas are best done as first case in the morning. So the evaluation of adrenergic blockade is using the Roizen's criteria. Arterial BP should be less than 160/95 in the last 48 hours prior to surgery, and it is preferable that to measure it in a stressful environment. And mild orthostatic hypotension is a good thing, and ECG should be completely normal. There should not, even ventricular ectopic, less than 1 in a 5-minute period. Now, beta blockade. So as I said, the first step is to give alpha blockade. About 7 to 10 days of alpha blockade, and about 3 to 5 days before the surgery, we introduce a beta blockade. It is started only after the alpha blockade is now completely, strengthened up. The advantage of beta blockade is that it reduces the side effect of alpha blockade, like reflex tachycardia and arrhythmias. But if you're going to have a cardiac failure environment like a cardiomyopathy, it's best to avoid the beta blocker itself. The drug of choice is atenolol and metoprolol, but intraoperatively we use a drug called esmolol. Beta blockade should never be started prior to alpha blockade, should never, because once you cross a beta blockade, it stops a beta 2 receptor, and what happens is the epinephrine's effect on alpha receptor block, it causes the antagonist causes a potentiation of the action of the epinephrine on the alpha 1 receptors, because the arterial dilatation of the beta receptors goes off. So beta blocker should never be started without the alpha blocker well settled in. Sorry, slide has to move. Yeah. Some selective alpha blockers are available, like terazosin, doxazosine, prazosin, but I confess in our unit only phenoxybenzamine is used. We don't use the other drugs. As I said, I'm going to briefly mention about catecholamine synthesis inhibitor. It's called met-tyrosine, alpha-methyl-tyrosine or met-tyrosine. I have used it only in UK, not in India. What it does is that it inhibits the tyrosine conversion to tyrosine hydroxylase and therefore to epinephrine. Started as 250 milligram per orally twice a day or thrice a day. It can be increased further on. Has a lot of side effects, especially CNS side effects, including extrapyramidal symptoms. So hardly it's used. In India, we never use it. The calcium channel blocker is a wonderful drug in pheochromocytoma, because if you are going to have it helps in augmenting the effect of the alpha blockade without the side effects that comes with the alpha blockade. 1 to 2 days before the surgery, a patient is admitted. Usually we admit 48 hours before the surgery. Every 2 hours, blood pressure is monitored both when sitting and lying down postures. A mild postural hypotension is a sign of an appropriate blockade. Intraoperative volume is restored with about 2 liters of bolus night before the surgery. This chart is available for anybody who wants to look through it. Now the patient is coming to the theater. What are the anesthetic aspects? The night before the surgery, as I said, 1 to 2 liters of fluids are given. The last dose of phenoxybenzamine is given the night before the surgery. The next morning dose is held. And because of ECF expansion, patient may have a relative anemia. Keep in mind that patient's oxygen carrying capacity might be low, especially Indian patients. Average hemoglobin is 10. After all the dilution, it may come to 7 or 8. So ensure that the adequate backup is made for that as well. The pre-medication that we give is usually benzodiazepines, diazepam. Opiates are not given because they can invoke a catecholamine release. And buprenorphine is the one which is given as an analgesia. Atropine glycopyrrolate is all completely not given. If domperidol is given as an antiemetic. In the operating theater, we need a good intraarterial access line, a very good setup of infusion pumps with phentolamine, sodium nitropyrroside, and esmolol, and for the after the operation, a noradrenaline infusion, a vasopressin infusion, and super duper cardiac monitoring, continuous monitoring. So as I said, this is a teamwork of endocrinologist, physician, a cardiologist, anesthesiologist, and of course ourselves as well. So the drugs that are chosen very carefully. Nothing is done to sensitize the myocardium. Arterial line and venous line is placed. 2 wide bore cannulas are placed so that resuscitation can be done. In the operating theater, there are 3 critical steps: intubation, induction and intubation, surgical manipulation, and management after the surgical ligation. So in the induction and intubation, very smooth. Oxygenate the patient. Of course, make sure the patient has adequate benzodiazepine before. No noise inside the theater. Absolutely, number of people inside the theater should be very, very minimal. Preferably, the familiar faces are inside the theater, not some new nurse who walks into the place. No use of fentanyls. Induction is done with a propofol and midazolam, and usually we use a laryngoscope for tracheal intubation after adequately anesthetizing the trachea. And increase the ventilation, increase the depth of ventilation very quickly with a volatile anesthetics. I will give a list of drugs that should not be used. Make sure the volatile anesthetics are used. When it comes to muscle relaxants, standard succinylcholine, atracurium should not be used. The special drugs such as mercuronium or rocuronium has to be used. For this surgery, you cannot use the standard drugs here. Positioning, make sure your OT technician who is your friend, don't move the patient quite drastically. Inevitably, most of us are doing it through minimally invasive approach. Patient goes to a full lateral approach for that. Once anesthetized, the patients are maintained on gas and narcotics. Volatile anesthetics are very easy to titrate and easy to manage the hypertension as well. Normovolemia is maintained. Exceptionally close monitoring of blood glucose is important. And patients are inevitably, as I said, I don't use nitrous oxide at all, N2O at all. So air oxygen mixture is given. Usually, as I said, opiates is kept to bare minimum. The catecholamine release during the tumor handling inevitably will happen in spite of super control that you have taken. And during that, there will be extreme increase in systemic vascular resistance and drop in the cardiac output. So you have to deepen the anesthesia and careful handling of the agents and the medication. That's why we tend to have a cardiologist, endocrinologist, and the anesthetist inside the theater. The medication for hypertension, that is during the surgery, sodium nitroprusside, nitroglycerin, and some amount of alpha blockers such as phentolamine can be used, but we tend to use sodium nitroprusside and nitroglycerin. And the beta antagonist is esmolol. As I said, esmolol really has helped a lot in our adrenal surgery. So we use it during the surgery, and it helps us to manage things better. And it has a rapid titrability. It is very, very suitable for this surgery. Another drug which is excellent for use is magnesium sulfate, very commonly used in labor wards, and you can use it to handle, especially when the tumor handling is happening. Then as the doctors in the next 2 topics or 3 topics will tell, the first step is to go and stop the adrenal vein. That is the first important step. Once you stop it, the circulating catecholamines will drop dramatically, causing serious hypotension. The moment you put a clip in the adrenal vein, take your hand off, stop manipulating the tumor, tell your anesthetist, say that I'm stopping the surgery for the next 10 minutes. And they have to resuscitate the patient at that point of time, give fluids, readjust the medication so that they bring the patient to normotensive one more time. As I said, at this point of time, vasopressin is very, very useful because you have given adequate alpha beta blocker. More and more pumping in noradrenaline may not help the patient. The anesthetic agent, as I said, to be avoided is a huge list here. You can see that the standard drugs that we use should be avoided. And during the extubation, the reversal depends upon the patient's perioperative and intraoperative course. Neostigmine and glycopyrrolate is used, but this is after the surgery, not before. And shift to ICU, MDCCU. We keep the patient in ICU for at least 24, if not 48 hours. All lines should be intact because the patient is still susceptible for very labile BP. And also keep in mind, all the time I'm telling you, hypoglycemia is a very important aspect in the perioperative management of pheochromocytoma. And the postoperative period, as I said, 2 important aspects: hypertension or hypotension. Hypertension may be related to the recovery from anesthesia. Make sure adequate pain relief is given. And if you strongly think there are extra adrenal sources, or you feel the patient has developed a resistant hypertension, you may have to restart the hypertensives. And the hypotension, which is more common to be found because of the suppression of the contralateral adrenal and the down relation of the adrenal receptors. So patient needs a good resuscitation at that point of time. And also keep in mind, there is an possibility of a bleeding from the surgical site, because adrenal vein drains directly into IVC on one side and renal vein into either side. The hemologs or the metal clips may slip off and can cause bleeding as well. As I said, hypoglycemia is an extremely important aspect of the postoperative management. Patient may have encephalopathy, and because of beta blockers, you may not know that they are having encephalopathy. So frequent monitoring with blood glucose is required, and they have to be resuscitated accordingly. So it's a teamwork. It is not us alone. It is a combination of the anesthetic, the endocrinologist, the cardiologist, physicians all together. But as Professor N.P. Gupta rightly said, the outlook of pheochromocytoma surgery has transformed phenomenally. We are in days now when patients can go home comfortably and well, and it is the duty of our team to ensure that it happens. Thank you so much for the opportunity for me to give a presentation here.
Thank you very much, Dr. Raghavan. It was again always excellent presentation. Such a difficult topic, and you have summarized so well. And I still remember Professor N.P. Gupta's wordings when we were his residents, that the surgery is not important, perioperative management is more important than the surgery. So I think I will request Dr. George Casso to give his comments if his protocol is different from what Dr. Raghavan has shown for pheochromocytoma. Dr. Casso?
No, we're very similar. The way we commence with the blockade and the expansion of the vascular system, and then follow it up. So no, we're very much in line with what he said, and a very excellent presentation.
Thank you very much. So now we move to again a very important topic.
Anup, I like to make comment.
Yes, sir. Sir.
Okay. Thank you, Raghavan, for giving very extensive cover on this topic. I like to add something about the use of alpha blockers. I remember that in 1975 when I joined, at that time phenoxybenjamin was used as a alpha blocker. But later on, the problem with phenoxybenjamin was it was a long acting, and if there is a hypotension during surgery or after surgery, it is difficult to manage. Then we have now short acting alpha blockers, and alfuzosin is the drug of choice. That is commonly what we are using 3 times a day, and we do the monitoring, and we do a PCV, packed cell volume of the patient from day 1, because of the vasoconstriction there is a high value, and when it we titrate and gradually see how it is dropping. When it becomes stable, it means patient has full vasodilatation. So that is the one point. Nowadays we are not using phenoxybenjamin anymore. The second thing I want to tell you, the use of calcium channel blockers, which you have very rightly said, because there is a cardiac toxicity of the catecholamines, and to prevent that, it is better to use, we can add calcium channel blockers in these cases. And if tachycardia persists, then only we use the beta blockers, otherwise not. So that should be the protocol. I think so. Catecholamines was the drug in the past, but nowadays we don't use anymore. Thank you very much.
Thank you, sir. Thank you very much for your comments. We move to the next topic, step-by-step approach of lab transperitoneal adrenalectomy by Dr. C. Mallikarjun. He again doesn't need any introduction in the gathering. He is our president-elect of USI. He's the director of Asian Institute of Nephrology, Urology, and he's again can be called as the father of laparoscopy in India. And of course, he's a great robotic surgeon also. So over to Dr. Mallikarjun.
Thank you for the good words, Anup. I think you're talking on the transperitoneal laparoscopic adrenalectomy. Am I clear? Audible?
Yes.
Yeah.
Yes, sir.
Yeah, go ahead. So, well, I think Raghavan and Brijibhanu has given a fantastic detailing about the preoperative preparation and anatomy is concerned. The points to remember, as has been said, whether it is functional or any chance of malignancy. Most of the time we do see more than a 6 centimeters, sometimes even 4 centimeters, we can think about a malignancy. And I would always expect these patients to take consent for nephrectomy, because majority of these truly malignant ACCs do derive some blood from the capsule of the kidney, and it's a messy operation if we need to take. So sometimes I've done once or twice a nephrectomy in these patients. I do take a definite consent for that. The second thing is optimization has been very well covered by Raghavan. I don't think I have anything to add. But one small problem, one small point which I wanted to emphasize was just clipping the adrenal vein alone is not enough. In my feeling that only 50% of the times, once you clip the adrenal vein, the main adrenal vein, there is a pressure drop. And majority of the times it may not drop at all till each and every small vessel which is coming into the adrenal is clipped and the adrenal is taken out. The adrenal tumors don't have a capsule, so it requires a careful handling. Never hold an adrenal. That's the first principle. You'll rupture the adrenal. So never hold an adrenal. Never try to take out an adrenal tumor without bagging it. So don't try to hold the adrenal, and use a gentle push across the gland whenever you're taking it. This is a right-sided adrenalectomy. If that is the point of adrenal gland and that is subcostal margin after pneumoperitoneum, that's a 60-degree angle which we do. We tend to rotate the usual ports a little towards the cephalad side when compared to the routine transperitoneal nephrectomy is concerned. That's for the liver retraction, and that's the first port which is going in under the subcostal area, and under vision we pass the rest of the 2 ports, the right hand one and the trocar and the optical trocar. That's a right hand one, left hand port, and in between with a triangulation you get the optical trocar. This is standard way of approaching any transperitoneal adrenalectomy, and that's the liver retraction which has come in the xiphisternum, just below the xiphisternum, and taking it out. You have to take out the small adhesions between the peritoneal adhesions between the liver and the peritoneum and bringing it down. And it always starts by identifying the lateral border of the IVC and creating a window into the peritoneum just above the renal vein. And that is the IVC which is seen very well. You identify the IVC and then make a window just lateral to the IVC. You just create a window, you push your left hand instrument inside, and you'll be getting into an area where the psoas muscle is there, and that you can see the psoas there. So that gives the leverage for you to dissect below the whole posterior surface of the adrenal is already dissected, and you find a small vessels coming up. That's a middle adrenal arteries or middle adrenal vessels. I would say, I don't know whether it's an artery or a vein, but anyway, it's a tough structure, so I need to clip it off. So after that, that is the first window which is being created. I would never take out the posterior, caudal one I'll do it at the later part. So first thing is medial, next thing is superior, next thing is going to be the inferior part, and the last one is going to be the lateral part. So that's a peritoneal incision which is given all along the liver, and then the division of the peritoneum which is done right up to the lateral aspect of the adrenal. And then that will create a window bigger, and you start dissecting into the loose fat what is existing. You just need to have a sucker or a dissector to just take out that loose fat which exists, which exposes the pedicle of the middle adrenal arteries. That's a pedicle of the middle adrenal arteries. That's a bunch of arteries. It's not a single one. It's a bunch of small vessels which come in. We are not clear. Sometimes the neural plexus also will be there. And then that is the division of the middle adrenal. So the window becomes bigger. Now you try to go cephalad, and you will be exposing yourself with a adrenal vein. That is the adrenal vein which is entering into the IVC, and you can create a window very well. And that's a small window which is being created, and you divide that and then clip the adrenal vein. Usually use only 1 or 2 maximum, and you can see the lip of the kidney, lip of the adrenal, which is very clearly seen. That's the 2 vessels which are with 2 clips and 1 more clip which are kept, which is not a routine in all the cases. So after division, that's the whole medial aspect of the adrenal is mobilized. Now we go superiorly. You start dissecting. Blunt dissection is enough. You don't need any much sharp dissection here. A blunt dissection and small adhesion between the diaphragm and the superior border of the adrenal which is there. And after that, you will come across the superior adrenal artery and the superior adrenal pedicle which drops down from the phrenic artery, which is being clipped. I do have a habit of clipping all these vessels. It doesn't appear that it is necessary, but I do have a habit of clipping all these vessels. So that the cephalad part and the medial part is completed. So now you divide the peritoneum just on between the adrenal and the kidney, and extend that incision into the peritoneum. That is an extension into the peritoneum. I leave that small peritoneal attachment or a peritoneum attached to the adrenal itself to handle it well after that. So create a plane between the adrenal and the kidney. That's the superior part of the kidney and the adrenal gland. On the lateral aspect, that's not a problem. It is very well created, very easily created. When it comes to the medial aspect, beware. You may have a upper polar renal artery which comes in the way, or that may be supplier for the inferior adrenal artery. So a blunt dissection there, a careful dissection is necessary. You may sometimes we have injured the upper polar artery, the small polar twig which coming into the upper pole of the kidney and has been injured. And you'll see a small vessel clipping off coming out of the renal artery area into the adrenal gland, and that's a lower adrenal artery. So 3 arteries and vein clearly identified. And unless we clip all these vessels, majority of the times we don't see the pressures getting under control. So we make it a point that it's just not adrenal vein, and all the other twigs also need to be divided. So now you have mobilized both inferior, medial, and superior borders of the adrenal, and what all you require is a child's play now. You just clip the adrenal, and inferiorly you completely do the mobilization inferiorly, and then the last step is going to be dividing the attachment on the lateral aspect, which is adherent to the diaphragm area. Beware, sometimes diaphragm can perforated, especially when a harmonic is used. So that is adrenal gland which is completed, lifted away and brought out from the fossa. Inspect the fossa at the end, have some saline onto it and see for any small bleeders. And if there is nothing, you may put a drain or you may not put a drain depending upon your choice. But I usually avoid a drain if it is such a simple case and clearly straightforward case. In this case, that is the case which is done, and the adrenal gland is always bagged into a bag and then taken out, never taken out directly from the abdominal wall. And the next case is going to be the similar, that's a left to one, a similar port distribution on both sides. And that is the thing. And you'll find a telescopic trocar coming up, and you can have only 3 ports in this area. You don't need a 4th port, and all the 3 ports are being kept. And this is a left adrenal tumor, small tumor in the left adrenal gland. The majority of the times the first intent I would say is mobilize the splenorenal ligament and attachment of the diaphragm completely. Let the spleen should fall away. You should not be requiring any retractor to retract the spleen as we do it on the right side. So you should be able to see the greater curvature of the stomach onto that aspect, and then it should not be falling onto you all the time. So that's a division in the gyrotous fascia which is being done to allow the spleen to fall away along with the gyrota, medial aspect of the gyrota. So that spleen should be falling away, and that's a pancreas which is being dissected away from the adrenal gland and the gyrota. So that's a gyrotal opening, and you can see the adrenal gland with a tumor. And the same procedures. I would concentrate on the medial aspect of the adrenal all the time. So that is the division. The medial aspect of the adrenal is dissected, and you pass a dissector into the and expose the psoas muscle, and that is the middle adrenal pedicle which is being clipped, and that is divided. And now you proceed upwards. You may have this case doesn't have the superior adrenal artery. That is a place where you get the superior adrenal artery, a branch of the inferior phrenic artery, but we didn't find any big artery in this, and so we divided it off. Now you come towards the inferior border. You will be able to identify the left adrenal vein. That's the left adrenal vein which is dropping from the left renal vein, and then the pedicle of the inferior pedicle, which is very clearly seen now. So you dissect it off. Both of them are clipped and divided. That's the dissection of, and you can see a small adrenal gland which is pushing towards below the vein and going towards the kidney. So division, and then dissecting the gland away from the adrenal vein. So now the inferior surface is being dissected. It's a blunt dissection. You don't have any vessels coming up. You have a surface of the kidney which is very well exposed, and the lateral attachment is still there. You're going to divide it with a whatever vessel sealer you have and divide it off. Now the last attachment, what is there towards the renal pedicle, which is going to be done at the last. I don't want to be done very hesitantly at any point of time, because sometimes renal arteries or polar segmental branches of the renal artery will make a U-loop there and then come towards the hilum of the kidney. So beware of this step at this point, like an upper polar vessel on the right side. There should be an injury that of the segmental vessel of the renal artery that can happen. So dissect it completely. If necessary, you reclip the vein, it's a proximal level, and then divide the vein again. So you should be careful about not injuring anything inside the kidney. That's more important. The hilum of the kidney is very near on the left side. So beware, all the dissection has to be done. The adrenal has to be suppressed. See that adrenal is coming right up to that point near the hilum. So make it sure that you are taking it out completely if you're not planning a partial adrenalectomy, which is very uncommonly done nowadays. And that is the division of the left adrenal. And that is the fossa what is being created. So at the end of the thing, thank you very much. Keep the adrenal, keep the attachments intact, have a peritoneal surface so that you can attach or hold the tumor. Never hold the adrenal per se. It ruptures and it makes a mess. Thank you very much for the opportunity.
Thank you very much, Dr. Mallikarjun, sir. Again, very excellent presentation, explaining both right and left tips and tricks to do the lap adrenalectomy. And I will request Dr. Hoffner to please give his comments. Again, he's a fantastic laparoscopic and robotic surgeon. So do you want to add something to this presentation, Dr. Hoffner?
Good morning, everybody. This is a good opportunity for me to join your webinar this day. This is an excellent presentation from my friends, and I think it's very important when you do the adrenal surgery, it's very important to have a good exposure of the fields. And this is the reason that, like he said, it's very important for the right side to put the liver very high in the field to be sure that you can dissect correctly the IVC and to show and to see exactly the adrenaline vein. And at the left side, it's also very important, like he showed us the dissection of the spleen to be sure that you can do exactly what you want on the adrenal gland.
Okay, thank you very much, sir. So now we move to the next important topic. Sir,
I'd like to highlight one more point here, what Dr. Mallikarjun had said at the end. So this reminds me the statement that in the adrenal gland, we should not dissect the gland from the human body, whereas we should dissect the human body from the gland. So this point I want to highlight, which he mentioned at the end, just to say that during surgery, we should not put any traction or anything or pressure on the adrenal gland till you have ligated all the or clipped all the veins and all that. I think so that is very important. And if surgeon, he has shown very nicely, but we should not handle, because in laparoscopy, surgery may be more and less in robotic. That will be the tendency to put a traction all the time. So I think so that should be avoided. Thank you very much.
Thank you very much, sir. It was again words of wisdom and to be followed by our youngsters. We move to the next important topic, retroperitoneal minimally invasive adrenalectomy by Professor Renal Kumar. Again, he doesn't need any introduction. He's again a renowned uro-oncologist from Kochi, and he's doing a phenomenal work in this field. So I will request my dear friend, Dr. Renal Kumar, to show his presentation.
Thank you, Anup. It is a great opportunity and great privilege for me to being invited from NOTTO for this meeting. Retroperitoneoscopic surgery is something that is very close with me, because I feel that a lot of structures in the retroperitoneum has to be approached through the retroperitoneum itself. Lateral is one of the gland, because it is, as Nayak has rightly told, it as anatomy is very complex. We have to reduce the manipulation. So best approach will be retroperitoneal, especially in the right side. Left side, it is very easy transperitoneally, but right side, transperitoneal sometimes is very difficult, because adrenal can be just behind the liver. So I'll just give an overview of retroperitoneoscopic adrenalectomy. We have a good bulk of adrenal, so we could move on to retroperitoneoscopy. This is very useful in right side adrenalectomy. So first I will go for a position, port placement, and how we create the space. Most usual position is the lateral decubitus, and we mark the structures, the costal border, iliac brim, and the right border of paraspinous muscle. These are important landmarks we have to be clear about. Other options in retroperitoneoscopy are supine position, where we can do a retroperitoneoscopic surgery when the structure is infrarenal, like in an extrarenal, extra adrenal location is there for the pheochromocytoma. This is another position is prone position. We have done a few prone position surgeries for especially when we want a bilateral adrenalectomy or when there is multiple surgeries like liver transplant. This patient actually had a adrenalectomy in the post liver transplant scenario. So we approached from behind. So these are the other options. Retroperitoneoscopic surgery doesn't mean that always we have to go in the lateral decubitus. So I'm going ahead with a common positioning and the routine surgery for adrenal in the retroperitoneus, that is the lateral decubitus. I'm selecting the right side because that is a side on which we usually select retroperitoneoscopic surgery. And most important position relation is we have to identify the 12th rib, lowermost rib. Just below the 12th rib comes the camera port, and posterior working port is just in the renal angle, just lateral to the paraspinous, and in the same line anteriorly, just lateral to the lateral line comes the anterior port. So where we have to put the working port, we usually put working port at the lumbar petit triangle or in the just above the in the subcostal area, according to which area we want to retract. So most important obstacle for retroperitoneoscopic surgery in our setup is we don't have the access to these precious structures, the balloon dilators and the balloon tipped trocar. So this is a luxury for us. We don't have this access and is very costly. So majority doesn't go for retroperitoneoscopic surgery. So we have circumvented this problem. Initially, we used to use the balloon, the glove finger at the tip of red rubber catheter as described by renowned Indian surgeon Govt from Mumbai Hospital. So we initially started our surgery like this. So, but nowadays, then I shifted to finger dissection for putting the port. No, what we do is actually VC-port insertion. So just put the incision, put the VC-port under vision, just enter the retroperitoneoscopic area, then you dissect. That is the commonest access way in which we access the retroperitoneum nowadays. And the balloon tip catheter is not a big issue because if the tract is not that much large, usually air doesn't leak, and with the sutures we can avoid air leakage. So I'll just go through the steps. First step is to create the space. So we use the camera to just strip of the peritoneal cavity and make the space, and rest of the thing, the air preciousness. The most important thing is to identify this glistening Gerota's fascia. Just incise the Gerota's fascia, you are into a big room. So next step is to climb on the psoas. Climb on the psoas, you just climb, you reach just below the liver onto the adrenal, above the kidney, and most important landmark is the renal artery. So I'm climbing on the psoas muscle. Just nothing else to see, just strip off the loose areolar tissue on the psoas fascia, and you just go as much as possible creating the space. You can create glistening fascia, that is the entry into the adrenal space, and this is the renal artery. So these are the two parameters, and the adrenal will be sitting plumb on the psoas. So this is the adrenal that is sitting on the psoas. So these are some sympathetic plexus and one artery that is usually coming from the renal or comes here, that is inferior adrenal artery as described by Nayak. So next step is to identify the IVC above the level of renal artery. So that is a crucial step. So once you dissect this structures out, the sympathetic, some nerve plexus and the vessels, you can see the pulsation, that is the pulsation of the IVC. So just identify the IVC, climb on the IVC and strip off all fibrous tissue lateral to the IVC. As Dr. M.P. Gupta sir has rightly told, we have to dissect off the patient from the adrenal. One thing we were very skeptical about laparoscopic surgery. We used to. So this is the middle renal artery as discussed by Mallikji. Once these arteries are cleaved, we just dissect the adrenal all around. So the identification of the adrenal vein is the most important factor in the adrenalectomy. Just lift the adrenal and climb on the IVC. Dissect adequately from anterior aspect, you will reach the adrenal vein. So the manipulation can be minimum in retroperitoneoscopic surgery. So in the difficult area behind the liver, I find retroperitoneoscopic surgery is slightly better than transperitoneal approach. So we are just dissecting of the patient from the adrenal without manipulating the adrenal much. So this adrenal, you can see it is embedded in a dimple inside the liver tissue and would have been very difficult to approach transperitoneally. So we actually have experienced more than close to 200 patients of adrenal, and one curious thing is the dissection of in the laparoscopy, the concept of approaching the adrenal vein as the first structure doesn't make much difference because as Mallikji has rightly told, this is the adrenal vein that is coming up. Mallikji is right, sometimes they'll kill multiple veins, and even if you're just clipping one vein, the BP will not fall. So this is the adrenal vein, and sometimes it is very tricky to clip the vein. That is why I like to have laparoscopic approach for adrenal rather than a retroperitoneoscopic robotic approach, because I am very confident to clip myself than giving to my assistant, because the adrenal vein is very short and sometimes it can be difficult to clip for the assistant. If I am doing robotic, I usually clip with the robotic arm rather than with the with the help of the assistant, because sometimes it will be difficult for him to clip in between the robotic arms. Usually I prefer to have laparoscopy rather than robotic for adrenal. And this is the clipping of the adrenal vein. And as Raghavan has rightly told, we have to be careful about the BP fall at this level. If adequate hydration and preparation is there, that usually doesn't happen in pheochromocytoma. Sorry, yeah, it was going out of the picture. Yeah, so sometimes there'll be one extra vessel there, which you should be very careful, just above the adrenal vein. There is the liver from behind which the adrenal right adrenal lies. So this is the step two-step approach dissociative chromocytoma. And posterior adrenalectomy I haven't included in the prescription because a lateral decubitus is the commonest way in which we approach the adrenaline. Thank you very much.
Thank you very much, Dr. Janil. Again, excellent presentation. And I will request Dr. Rafael to give his comments upon this technique of retroperitoneal minimally invasive technique. Dr. Rafael?
Can you hear me?
Yeah, please.
Well, I think it's a great approach. I think the only concern that I have it's for adrenal carcinoma that I'm going to discuss in my talk. I think you need to have more space and have a better access to the kidney and to the vena cava, especially in those cases when you have invasion of the kidney or the vena cava. Then I think the transperitoneal approach is the best. But for the rest of the cases, I think it's a great approach. It's faster, bloodless, and you can have a great access to the adrenal vein. So we do sometimes with the robotic approach, robotic retroperitoneal adrenalectomies, and I'm pretty happy with this approach. I think it was a great presentation of a laparoscopic approach, and we use sometimes in our robotic experience as well.
Thank you, Rafael. I think now we move forward to the next minimally invasive technique, which is the robotic. And now we're going to have the robotic adrenalectomy step-by-step transperitoneal approach by Dr. Sudhir Rawal. Again, he doesn't need any introduction. He's the medical director and head of genitourinary in Rajiv Gandhi Cancer Hospital, Delhi. He's also our president-elect of North Zone USI, and he can be safely called the father of modern uro-oncology. So I will request Professor Dr. Sudhir Rawal, sir, to please give his presentation.
Thank you, Anup, for a kind introduction, and I'll just go on the presentation. As a cancer center, we are exclusive cancer center. We do get big masses, and we get less FEO than myelolipoma and big adrenal carcinoma. This is the patient. I'm showing one video only of right adrenalectomy. And here it is a 56-year-old male, hypertensive, controlled by single antihypertensive drug. He complained right flank pain for 15 days. Ultrasound of abdomen showed right echogenic mass in the right adrenal. CECT showed a right suprarenal mass of 8 into 8 into 7.5 centimeter, predominantly containing fat with few scattered soft tissue density lesions showing suggestive of myelolipoma. Metabolic evaluation of adrenal mass was normal, and probable diagnosis was right adrenal myelolipoma. So this the CT scan you can see, and in the next cut there will be a video of CT scan. So this is the video going under the liver. Plan was to do right adrenal robotic adrenal adrenalectomy, and we use XI system. We have both X and XI. So XI was used, and the port placement was like for the right nephrectomy. As you do the right nephrectomy, same way was the port position. Once you have done that, you go for the adrenal mass, and first you have to go for the upper border. As Mallika has shown in his presentation, you start mobilizing from there. With robot is probably one of the easiest surgery, which I feel, and for patient, I think minimally invasive surgery for adrenal tumor is the best. This is one surgery where minimally invasive surgery should be offered to the patient rather than giving a huge incision. And with the robot, you can do big masses also. Sometimes there is always fear of rupturing of tumor. So we have devised one just innovation for that. We put a gauge piece on the progress to retract the liver or to retract the adrenal mass when there is a problem or fear of rupture. After mobilizing the upper pole and the liver, we put a retraction as you have seen, then we go for the lower border, that is upper border of the kidney. And this will be showing the vessels will be coming different vessel as Brushman has showed in his presentation, the anatomy. Those vessel will be taken one by one. You see we are using 3 instruments. The progress was on that side. And it easily comes out. Yes, myelolipoma, they have very good plane. Even FIO have very good plane. Now we go for IVC medially. Taken one vessel here. Another vessel is coming. This is directly from IVC. This is a vein. It's a small adrenal vein which can be clipped. Need not to take such a big clip. You can take in a small clip, but here, then the next clip is a small. Then go up, where you will encounter main adrenal vein. You can see the vein coming now. There are vein coming from the caudate lobe also directly. Sometimes they can get injured if you are not careful, especially in the big mass. And there will be accessory hepatic veins also. So the right adrenal vein will be taken. It's not FIO, so there is no need of worrying about BP. One should spend some time in this dissection. There is no need to hurry. And then another branch is taken. It actually is going to the liver, and so sometimes accessory hepatics can join the IVC at the insertion of adrenal vein. So you should be careful at this steps. It's not a big problem if you are dissecting it. Vein per se, they don't cause much problem in robotic. Once you have done that, you go further down towards the source, taking small arteries. Here is the artery. You can buzz there. We generally buzz them rather than clipping. You can see the source here now. Posteriorly, there is nothing. You just have to dissecting. Small arteries can be clipped and cut. and then you can see the rupture. If ruptures occur, this is the technique which we use. We put a gauge piece on the progress, or if we see the impending rupture is there, then you can use like this. This is less traumatic or almost atraumatic, but this was a big tumor. Being myelolipoma, there is not to worry also, but then this is one thing which can be used in robotic. And further clipping the arteries. The mass is removed. The lateral attachments are taken finally, and the specimen will be bagged and see, this is just fat. So we put a specimen in a bag. It's a custom-made bag in the theater only, and it comes with a small incision from the abdomen. Operating time was 60 minutes, blood loss less than 50 ml. No drain was placed, post-op recovery uneventful, discharge non-PO, post-op day 2. Histopathology was myelolipoma. So thank you, Anup, and thanks everyone for giving me this opportunity.
Thank you, Dr. Sudhir Rahul, sir. Again, you have shown that use of robotic can help you to do minimally invasive surgery for such a large adrenal mass also. There is a question from the audience. In your experience, what are the contraindications for doing a robotic adrenalectomy? Any contraindication from your side?
Yeah, but if it's bigger than this, probably I'll not go for adrenal. Also, adrenocortical carcinoma. I think most, if it is size is less, we can go. But most of the time they are big, so we go for open surgery. The size probably is the only thing which, besides, I don't think anything else I can think of. You can easily remove with the robot. This is one surgery which actually has a lot of benefit when you do minimally invasive approach.
So what's the size cutoff you take when you decide robotic surgery for this patient?
Yeah, this was 8 to 10 centimeter is my cutoff. Another thing, on CT scan, if you see that there is a lot of peri mass reaction, you can see them. So better not to go there. That occurs in a adrenocortical carcinoma rather than myelolipoma. Myelolipoma are easier to remove, even in bigger than this.
Okay. Thank you very much, sir. So now we move to
Dr. Gupta wants to make a comment.
I want to ask one comment. I'd like to make one comment.
Yes,
now,
sir.
with the recent imaging, we can be very sure about the diagnosis of myelolipoma. So, what the question I want to ask Sudhir, what is your indication of surgery for myelolipoma?
So, is the bigger size and pain?
No, if patient have pain, then only you will operate, or asymptomatic also you will operate?
No, asymptomatic is small size. I'll keep him on follow-up.
No, because I have patients up to 10, 12 centimeter asymptomatic, lying for many years without any pain, without functional element, then we can leave them alone. Actually.
Yes, sir, definitely. If they not have symptoms, we will not operate them.
And second thing is about the size. If you are dealing with the myelolipoma type of thing, then 10, 12 centimeter can be done robotic or laparoscopy.
Yeah.
Because there are no adhesions, there are not significant blood supply and all that.
Absolutely.
Thank you.
Thank you, sir. Now we move to the next topic, which is robotic adrenalectomy in a case of pheochromocytoma, in which we know it's a very tricky situation. And we have Dr. Jean-Luc Hoffner from Bordeaux, France. Again, is our dear friend. He has operated in our many of the master classes. He's a fantastic lab and robotic surgeon. He's a very, very renowned uro-oncologist. So it's my pleasure to invite Dr. Hoffner to please give his presentation.
Okay, thank you, Anup. Do you see my video?
Yes, sir. I mean, we cannot see your slide. Please share your presentation.
There is no presentation. I have only the video. But this is a woman for.
Sir, we cannot see your video, sir. Please share again.
Okay.
We are just seeing the Zoom written over there, sir.
Okay. You don't see this? You
Yeah.
see?
No. Please minimize your video and then you click the share button after.
Okay. Okay. That's okay.
Still, sir, we are not seeing your video. So you please open your video, minimize it, and then you click and select that particular video, and then you share.
Okay. And share. You see?
Yes, sir. We can see now. Yes, sir.
Okay.
Yeah.
This is a video for pheochromocytoma diagnosed in the old woman after hypertension. This is an intra-abdominal approach at the left side, and we put the patient in the flank position. And it's very important to do the same dissection that you do when you do partial nephrectomy or nephrectomy. And even if you have to go to the upper pole of the kidney, it's very important, like said Malika, to do the good dissection of the spleen to be sure that you have a good field to manipulate the different things of the dissection to the adrenal gland. This is the incision of the gerotas, and the first step is to go to the vein, the adrenal vein, and it's very important to follow the kidney pedicles. And the first thing that you have to see is the vein, the renal vein. And it's very important to be carefully. This is also very important to put the fourth arm on the gerotar fascia of the kidney to be sure that you have a good exposition of the field. This is the dissection of the gerotar, and we see the fat and the dissection of the small vessels. Very important to be sure. This is with telescope. This is a 13 degrees telescope. I think it's better to do the dissection for the adrenal and for also the different things of the upper pole of the kidney. And we can see the stomach there, and to finish the dissection between the diaphragm and the spleen, to be sure that the spleen is going down. And we can see the small tumor of the adrenal gland, and this is the reason that there is no big relief on the adrenal. It's very important to manipulate more the adrenal to be sure that there is no problem with hypertension of the patient, and to be sure also that there is no anesthetic problem. And this is the reason that the robot is very easy to do this kind of surgery, because this is only dissection of the vessels, and also to do the manipulation of small things. And there is a division of the adrenal vein, because this is the left renal vein, And this is the kidney. There is the pancreas there, and this is the colon in this position. Very important with the force arms to do the dissection and to be sure that there is no problem. This is always the dissection of the pedicles of the kidney. And like you see, this is a little difficult to be sure that there is some elements from the adrenal and other from the kidney. And I use for this kind of dissection the vessel sealer of Intuitive. This is like harmonic scalpel, and it's very good to do the dissection of the tissue and to dissect, divide, and dissect the small artery. In this case, there is a big adrenal vein, and we do carefully the dissection of the vessels to put after a clip and a hemlock clip in a good position. This is the assistant who put the clip. And you see the relief of the adrenal gland just there. And now we can put the clip in a look. This is a pink hemlock, middle size. And we can also check that there is no problem with the tension of the patient. And we can, in this case now, manipulate more the gland and to put more clips at the division of the adrenal vein. And to do after, to put the clip. This is the dissection between the kidney and the adrenal. And I try to have enough place to put the clip and after to divide the vessels before to dissect the rest of the gland. Okay. This is a metal clip, 10 millimeters. The totality of the adrenal vein is clipped, and now we can cut it very easily and very safely. And the rest of the dissection is to do the dissection between the kidney, and there is a little closing between the artery. You see the artery, and the next step is to see the psoas relief to be sure that you have all the things between the glands and the different elements. There is and with the vessel sealer, it's very easy to follow the glands and to do the dissection. You see the small vessels, and there is also vessels, but there is also lymph channels. I think very important to take everything. And in this case, we can see also the lymph nodes that you have to keep to be sure that there is no problem with lymphocyte. This is in this case very close from the artery. And with the vessel sealer, you can burn the vessels and cut after. The tumor is there. And this is the relief of the kidney there. This is the fat around the adrenal gland and the tumor. The tumor is not very big, huh? And you can see the dissection of the ileum of the kidney. I think for us, like urologists, it is very easy to do this kind of surgery because we know exactly the anatomy of the kidney, the anatomy of the vessels, and more now with the knowledge that we need to do the partial mastectomy. This is the reason that we can do, I think, a good resection of the adrenal gland. Because in France, there is some urologist who does this kind of surgery, but this is also general surgeon or endocrinologue surgeon who does this surgery, because it's very rare for urologists to do pheochromocytome because the pathology is rare, and this is the reason that you have to when you have an pheochromocytoma to operate, you have to refer the case in the institution where you can check correctly the patient before surgery, after the surgery, and during the surgery. And this is the reason that this is only for case center. And urologist now with a robotic approach is restart the dissection of the adrenal and restart the surgery of the adrenal. And it's very important to do very clearly this surgery to be sure that we can continue in this way. And you see, this is the small arteries from the middle, and this dissection can now to be freed totally of the adrenal gland. Sometimes it's more difficult when it is a small tumor than this is a big, because the big you can follow directly the tumor, and it's difficult to sometimes to expose correctly the tumor, but it's easier, I think, to do a big mass than a small mass, because small mass is always inside the fat. And you see, you reach the diaphragm now, and we can see exactly the upper hole of the kidney and the different attach from the kidney is freed and is finishing the dissection. There is no bleeding now. This is a surgery without bleeding, and this is the reason there is no a lot of pain after surgery, and this is the reason the patient can be discharged from the hospital the day after the surgery. And maybe we can even imagine that this is a surgery you can do in a day surgery. I think it is a possibility, but maybe for the pheochromocytoma is more difficult because of the hypertension. But I think for the surgery alone, it is possible to do in day surgery. This is the last section, and we do a small hemostasis of the fat and maybe of the superior artery of the gland. And you see exactly the kidney and the field where there was the small the pheochromocytoma, the stomach, and the artery and vein of the kidney. And we put in the bag and we move by lateral ports. This is the same bag where we put the prostate and that's finish. Okay, thank you.
Okay, thank you, Dr. Hopner. It was a very excellent presentation. One question from the audience: you have done so many lab and robotic now for few. What do you think is better in your hands, and why?
I think for me, the robot is now the great surgery for the adrenal gland. But if you don't have robots, lab surgery is also a good approach to do this kind of surgery, because this is the same steps than in lab and robotic approach, but I think with a robot is easier to do this dissection. Lab is difficult. It's always difficult, but if you have a robot, you can do this surgery very easily.
I agree, Dr. Hopner. I think use of robotic arm has helped surgeon doing difficult cases in a minimally invasive way. And so we now move forward to the next very interesting topic. It's a robotic. Yes, sir.
Anup, I'd like to highlight one point which Dr. Hopner has he has mentioned in his presentation. Now, with the development of the endocrine surgery as a super specialty, so we have also this program of MCH in endocrine surgery. So the endocrine surgeons are also taking interest in doing the adrenal surgery. So, and as he has rightly mentioned that this is a high time, the urologist should continue to do the adrenal surgery. Otherwise, we will be losing one more area from the field of the urology. I think so that's the important point, and we should continue to do the adrenal surgery.
Yes, sir. Thank you very much, sir, for making very important comment. And we move to the next important topic. It's a robotic retroperitoneal adrenalectomy. And we have Dr. George Casso. He's again a senior uro-oncologist and robotic surgeon from Miami. And his area of expertise includes adrenal pathology. So we are very pleased to have him today on the board. And we invite him to share his presentation. Dr. George.
Hello, and thank you. First of all, wonderful presentations by everyone so far. I was also quite heartened to see Ganil's presentation and to note that, you know, we also, I prefer to do a lot of these cases laparoscopically, but once in a while, a case presents itself that would be appropriate to do robotically. Because we also have the issue that other folks are taking away some of these adrenal cases from us. We do not have as much familiarity sometimes doing this with our OR staff. So our approach is going to be a flank approach, very similar to what we do with kidney cases. Anyway, for my video, the video itself is going to include my audio, so I will check in again at the end, and also a little Mozart for you all this morning. One moment.
Dr. George, we can't hear the audio. Can you please give yourself commentary if the audio is not there?
Yeah, let me see one moment.
You have to click share the computer sound sound also. When you share your presentation, then we will be able to hear your audio of the video.
Okay. So I have it on sharing sound, but give me one moment, please. Sorry, the presentation is closed on my end, so I have to reopen it. One moment. I'm going to try one more time. Are you able to hear?
We just seeing that you are starting. Now we can see your video. You can play it now, and we'll see whether there is audio or not. So the audio is still not there. So can you please give the commentary yourself? I mean, you can run the video and can you give your commentary?
Sure.
Yeah, please.
So this again, we're doing this in a full flank position. This is a morbidly obese patient who's been placed in flank so that her central obesity gets pushed off the table. This is the way that I would place the ports for the surgery. I always palpate where the 11th and the 12th ribs are, as well as the iliac crest. This is something that I do before I put the gloves on prior to surgery. Here's a schematic which demonstrates why the ports are placed in that way. Most critical, I think, is to come in with the camera port, which I do via Hassan technique through the lumbar triangle of Petit. Afterwards, the assistant port is placed in the anterior mid-axillary line, just ahead of the iliac spine. The three robotic ports are placed, first the most lateral one, just above the indentation of the erector spinae and below the 12th rib, which had been previously marked. And then probably most critically, the fourth arm is placed medially, right in the inferior aspect of the field, about 7-8 centimeters beyond where I had placed the other port. Now here you see the S retractors as we're beginning to and place the camera port. The tonsil pierces the fascia. And then I do a finger sweep, and critically during this finger sweep, you try to put your finger right above the psoas muscle and begin to create the space. But in this case, because of the obesity, only the tip of my finger is actually in the space itself. Now, as Ganil had shown, he does not use the spacemaker, and actually for laparoscopic cases, I do not use the spacemaker either. But for these robotic cases, we do use the spacemaker. One of the nice things about it is that I am able to directly visualize as I am making the space and preparing to place the ports. So this is a cross-section of the previously seen patient. You can see her 12th rib. And some of these patients, both because of body size and because the rib itself is short, it's hard to palpate. That's sort of the orientation you want the spacemaker to have on top of the psoas muscle, and you want to sort of drive it towards the hilum of the kidney. Now, using a 10-millimeter camera, we're able to directly visualize the space itself as it's being created. Here, you sometimes are able to see the ureter actually peristalsing medially. You can see the psoas tendon below. And here you can see the peritoneum being pushed off of the transversalis fascia. And that was my finger pushing down on where I know that the fourth and most lateral robotic port needs to go. Our ports are then placed under direct vision. And there's where the ports look afterwards. Now, because we're using an XI, we actually place the XI port right through the spacemaker port and are able to proceed in that way. Now, when we began this case, if you could look up to the upper right, you can see the very thin peritoneum. And instead of creating the space underneath the kidney, the space had actually been created above the kidney. And that's one of the ways someone who is not familiar with this case can disorient themselves. You can see that the spacemaker goes on top of rather than behind the kidney. So the fourth arm actually helps quite a bit when you do this incorrectly, because you can still push things away and still define the space as needed. Now here's a more ideal space. This is a different case. And here, as Ganil had shown in his surgery, the critical step is to divide this fascia, get right on gerotas, and begin to work one's way towards the hilum. And here again, a similar view, but now on the contralateral side. The steps, regardless of side, are very similar. It's also very important, as you'll see here, to keep this fat intact. One of the things that happens in these retroperitoneal surgeries is you need to manage the fat. If you cut that fat haphazardly, you'll then get a lot of fat dripping into the field, which will make things significantly more difficult. In a general rule, I would say one should lift the fat en bloc, and then you divide this thin tissue, again, similar to what Ganil showed earlier, in order to define the space and to begin the surgery. Here again is the patient that was being shown from the beginning of the video. Here, noticing that we were in the anterior space, I had to redirect posteriorly towards the quadratus laborum. The kidney is identified, and then, and only then, do you actually begin to produce the space and reorient oneself to behind the kidney. Again, as was noted with the laparoscopic case, the first critical portion, once the space is defined, is identifying where the artery is. And there you can see the artery dropping into view. And then one knows that once this has been identified, the adrenal is going to be just behind it, just beyond. Again, on the contralateral side, very similar. The artery is again noted, it can be dissected, and you proceed going superior to it. So once the artery's been identified, you start creating this portion of the adrenal that is closest to the renal hilum. The base of the inferior vena cava can be seen there, and you begin dissecting off the adrenal gland. So here on the left side, I'm having my assistant clip. Again, to the point that's been made before, one has to have a lot of confidence in your assistant, particularly if they're doing this. And so when I do this, I have to prepare it. I have to be ready for what happens if my assistant misses with a clip, if the clip is placed incorrectly, if there's immediate bleeding. The application of the clip, again, it's easy to spread using the robot and then divide the vein. And again, we start now pushing the adrenal mass bluntly away. This is sort of the way that we have our operating room set up. There's my assistant, the one who just placed the clips, cleaning my camera and pushing it in. Again, you want your assistant to have good ergonomic space with easy access to the assistant port. So after dividing the larger vessels, we begin to dissect underneath. Again, keeping in mind that the diaphragm is just off view. It's quite easy to spread, divide, using the robotic arms, using the Maryland. And here we see the large mass on the upper left of the screen as I pull back. Here's a different case, one where we're doing it not with a large mass, but one that was being done for overproduction from the adrenal gland. And you can see that, you know, we can not only do the larger glands, but we can also do these smaller ones. Quite easy to divide the attachments between the adrenal itself now and the upper pole of the kidney and completely free up the adrenal gland. So large or small, the retroperitoneal approach can be quite useful. Here we bluntly go pushing this large mass off. Now, we've talked about the size criteria that some folks use. In general, we try to not do these retroperitoneal surgeries in masses greater than about 6 centimeters. You can see this was about the size of this mass as it was resected. This is what the incisions look like at the end of the case. The patient, of course, will suffer from very little morbidity from this surgery, particularly very little bowel morbidity. And thank you very much for allowing me to share the technique with you.
Thank you very much, Dr. George. Excellent presentation. There's one question from the audience. In your experience, when you do retroperitoneoscopic robotic adrenalectomy, what's your experience about adrenal carcinoma? So do you think some limiting factors when you use this approach for adrenal carcinoma?
I think, you know, everything depends on multiple factors, patient factors, you know, what the anatomy looks like at the time, what the CT scan looks like, what you believe the extent is of the disease beyond it, surgeon factors, how comfortable one is with the approach. You probably would not want to do a large carcinoma as one of your first cases in your series. You know, your OR staff, the people you have around you. When you're doing robotic surgery, you have to have people that you trust. So if you have assistants that are unfamiliar with the procedure, again, it may not be a good case to do. So you have to take all of that and, you know, then you just make the right choice for yourself and for the patient.
Thank you very much. So now we move to the last session of this video part, and I'm going to show one challenging case of robot-assisted adrenalectomy, and this is followed by Dr. Rafael. So I hope you can see my presentation. So this was a case, 23-year-old female, presented with weak right flank pain for last 1 year. BMI was 32, and on evaluation we found this mass in the right side adrenal gland, 6 by 4.3 centimeter. So we did the functional evaluation of the mass, all was negative, so it was a non-functional mass. and we thought it would be a right adenoma, which is non-functional, and planned a patient for robot-assisted transplant adenectomy. So this is a typical port configuration. We use XI Robo and all in the same line, and we use AS seal especially for a high BMI patients. And this is the second assistant port. So now, once we started this case, we started with the mobilization of the colon, and starting the mobilization right up to the subhepatic area, and exposing the adrenal mass. And as highlighted by previous speakers, it's very important to have a good exposure of this area, and including the IVC part. So now, then we started the medial dissection of this mass. We found that the plane was not very good. And as we find in other cases, there was some kind of desmoplastic reaction all around the border of IVC. So that's why we took our time to make a plain, sharp and blunt dissection. We did between the medial border and the IVC. We got some plane in some areas, but again it was stuck in some other areas. And gradually we did the dissection in the medial aspect, and you can see that still the planes, they were not very good there. So gradually when we proceeded, and we were looking for the vessels, the adrenal vein in this area, and slowly, gradually, we encountered this was the first vein. And again, you can see the short vein going into IVC. And as highlighted by Dr. Janil, I also prefer to put a robotic clip applier in these cases, because it's a very small friable vein, and I don't want my assistant to just traumatize this vein. So as we proceeded further, inferiorly medial aspect, we found another big vein there, and we dissected and we clipped this. But as then we proceeded further downwards, then we can, these all small attachments we were taking down. But as we moved more down, we found that the mass was stuck to the IVC in the lower part. So we thought we will first mobilize the upper part and supromedial aspect of the mass. And then here you can see, this is the IVC, and this was going right retrocavally. The mass was going behind the IVC, and absolutely there was no plane here. There's a lot of desmoplastic reaction. So that was one of the challenge we faced, retrocaval extension and desmoplastic reaction. But slowly, steadily, we made the plane between the IVC and the middle border of this mass. And we tried to go along the middle border, and we found plane, and therefore we proceed further. There you can see that's the part going behind as IVC. So then we, as you can see there, we got some plane, and we are taking care of the vessels there. So at this particular point, then you can see that right there, now we are lifting the IVC medially, because this all is retrocaval. So the whole mass and the vessels, they were going retrocaval. So we have to lift and medially the IVC all the time, and then we are doing the dissection behind the IVC. This was one of the challenge we faced, and I am using again robotic clip applier, so that I don't want to injure anything behind the IVC, because it will be very difficult to then manage that complication. Therefore, I used a robotic applier, clip applier and all those. And then here, as you can see, I just want to stop here. This is the renal hilum. This mass was grossly stuck adhered to the renal hilum. This was my second challenge. So my aim was to salvage this renal unit. And therefore, I tried to make a plane. Then I thought it's very stuck. So I then went up, and I went to the lateral aspect. I thought I will dissect the mass all around. Then I will come to this area in the last, and that's how what I did. So laterally, and then this is the inferior portion of the mass. We are going slowly, steadily, and now we are coming towards the hilar area. So that's the renal vein, right, coming there. And this mass, there's a lot of desmoplastic reaction engulfing this area. So I took my time. I made a plane slowly, steadily, not injuring the main vessels, and slowly, steadily, we were successful in making the plane, as you can see right there. And we went behind this mass, and now whole the mass is lifted up, and this is the only attachment left behind. And therefore, we were now very, very confident that we can salvage the kidney and we can take out the mass in toto. And that's how we did. And finally, we just removed it without any complication and with a good hemostasis. So this was the mass, and then it was bagged, as earlier said. And then we sent this mass for the histopathology. So this was the mass, and who was surprised, it is adrenal ganglioneuroma. So just few points. In this patient, it was challenging because it was having retrocaval extension, and it was adhered to the renal hilar vessels. So the adrenal ganglioneuroma is a very rare adrenal tumor arising from neural crest cells. A very small case series and case reports have been there in the literature. Most common site is retroperitoneum and posterior mediastinum. Most common age group involved is 4th to 5th decade. Males and females are equally involved. Normally it is non-functional, but 30% patients can show increased urine and plasma catecholamines along with some other markers can be raised. And surgical resection is often having a good prognosis with no recurrence. In a series of 50 patients, there are 2 recurrences and 1 metastasis only. But in our patient, you can see it was a different kind of patient with desmoplastic reaction, and it was going retrocavally. So this is what I wanted to show. And this was a histopathology which shows Schwann cells, perineural cells, ganglion cells with fibrostroma. And these are the ISC stains which marks diagnosis of ganglioneuroma, NSC, S100, and Vimentin. So we have done last 3 years. This is a prospective data of 57 patients, robotic and laparoscopy, and mean tumor size of 6 centimeter. We have operated for various pathologies. Operating time is around less than 2 hours. Blood loss was again around 140 ml. We had 3 conversions in a case of large FEO and a case of carcinoma, but there was no untoward complications. Histopathology, we have majority is adenomas, then pheochromocytoma, now 2 cases of ganglioneuromas also. And in the follow-up of around 3 years, we have seen that patients have good response to hypertension, resolved or improvement of the hypertension in these patients. So thank you very much for your listening. And if there's any question, I will be happy to answer.
Anup, small comment. I had a similar patient. We did retroperitoneoscopically. The similar appearance was there for that patient also. There will be multiple connections to probably to the ganglions in the sympathetic system. What you see as extension retrocavity can be the attachment with the ganglions in that area. So this will be like connected everywhere around, and it usually goes behind the IVC. We have to lift the IVC. So it was around 4 centimeter, and we could manage by lifting the IVC robotically from behind.
Yeah, exactly. Dr. Janil, I think these are some cases where you cannot predict just on the basis of imaging, and you have to be prepared for surprises. But I think with the robotic, I am totally agree. It gives us so much of liberty to deal with these cases, and we can manage them successfully. So now I think we move to the next very interesting presentation by Dr. Rafael. And now Dr. Rafael is my dear friend. Rafael Coelho is a professor and chairman of Department of Urology. He's a very senior robotic uro-oncologist from Sao Paulo. And I will request Dr. Rafael to share his screen.
Okay, can you see my slides?
Yeah, please make it full screen. Thank you.
Okay, so thank you very much for this kind invitation, Anup. I'd like to give a word of caution on the use of minimally invasive surgery for adrenocarcinoma. So if you look at the literature, there are some comparative studies like this one from MD Anderson showing higher recurrence rates if you do minimally invasive resection of adrenocarcinoma. So in this case control study, if you look at peritoneal recurrences after minimally invasive adrenalectomy compared to open adrenalectomy, you see the survival is much worse in the minimally invasive approach. Even overall survival in this series was worse in the minimally invasive approach. So we have to be very careful selecting patients for robotic or laparoscopic adrenalectomy in the setting of adrenocarcinoma. Well, if you look at the literature, there are a lot of series showing higher recurrence rates in the minimally invasive approach, but there are also series showing similar results, which is the case from in this series from Francesco Porpigliac that shows overall recurrence actually higher in the open approach, and local recurrence is very similar between robotic and open adrenalectomy. And there are two other large series showing similar outcomes if you do it robotically, laparoscopically, or open. The message here that I'd like to give is we cannot rupture the tumor. So if you're doing a laparoscopic or robotic approach for adrenocarcinoma, you have to be very careful in your dissection. If you have any rupture of the tumor, you're going to compromise oncological outcomes, you're going to increase recurrence rates. So patients need to be very selected. And if you look at the guidelines today, for example, the NCCN guidelines for adrenocarcinoma, open adrenalectomy is actually recommended as the standard approach. And even in the SAGE guidelines, an open approach to resection may be best for adrenocarcinoma. So I'm not saying that we shouldn't do a minimally invasive approach for adrenocarcinoma, but you should do only selected patients, and you should be careful because guidelines recommendations are against us in these adrenocarcinomas when you do it minimally invasive. So select your patient carefully. Do not rupture, you cannot injure the tumor, otherwise you're going to compromise oncologic outcomes. I'm going to show a video of adrenocarcinoma done robotically. This is how I put my ports, exactly the way I put in for a partial nephrectomy. And I do even if I do similar if I have a SI or XI robot. I use all the trocars in a paramedian line. I have the camera port here. I have 2 robotic ports and 1 port near the iliac crest and 1 additional port for my assistant. That's how I do robotic partial, and I do robotic adrenalectomies this way. So this is the case. There was an 8-centimeter adrenal carcinoma in the left side. So it was invading the upper pole of the left kidney. So this is the kind of reconstruction that we do sometimes for this challenging case. So you could see the splenic artery, the splenic vein, and this is the posterior view. You see the close relationship between the tumor and the upper pole of the left kidney. So this was the case. I use a bipolar forceps in my left hand, the progress in the forearm. Here we are dissecting the tumor away from the spleen. Then we move straight to the renal hilum, where I would like to find the adrenal vein. And again, you have to be very careful. You cannot rupture the tumor, otherwise you compromise patients' outcomes. So you see, I try to not mobilize not touch the tumor while I'm dissecting away. So this is the renal hilum. We're going to find the left adrenal vein. So this is the left adrenal vein. And for the left side, this is my approach. I clip the vein and I try to dissect underneath the adrenal gland. So I think it's pretty easy to do it. And this way you avoid too much manipulation of the mass. So here we're dissecting away from the upper pole as much as we can. This tumor was invading part of the upper pole, so I had to do actually a partial nephrectomy without clamping for removing this tumor. So once we got to the parenchyma, so see, the tumor was kind of invading. This is the Giroda's fashion. And when I got to the invasion, I actually had to do a partial nephrectomy. I didn't clamp. Was just a small portion of the kidney that I had to remove. So this is the tumor. Let me move away. So we are dissecting the tumor posteriorly now and medially, and I left the partial nephrectomy to the end. So I have my assistant putting the Hemolox. I have a good assistant. We are together for many years now. So I don't use robotic clip apart in my cases. So we're finishing the dissection of the medial portion, and then I left the parts of the tumor that was invading the renal parenchyma to the end. So we totally release the mass. Let me show you the final aspect. So release laterally now, and then we're gonna do the partial nephrectomy. So again, you have to avoid injuring the tumor. So all I have now is the tumor invading the kidney. So I'm doing a partial. The hilum is not clamped. So it's a kind of enucleation. I just increase the pneumoperitoneum pressure, and I do a wet resection of the kidney that was invaded by the tumor. At the end, all margins were negative. So just finishing the dissection of the upper pole of the kidney. I could clamp the hilum, but as it was a small invasion, I didn't think that was necessary to do it. So I'm clamping, I'm finishing the dissection, and then I suture the upper pole of the kidney at the end. So I'm finishing everything. And then I suture the upper pole before I finish the resection of the rest of the adrenal tumor. So this is pretty straightforward. Again, we have to be careful. This patient knew that if we had any problems during surgery, we would convert it to open, and the final aspect was perfect. The margins were negative. So in selected patients, we can do a minimally invasive approach for adrenal carcinoma. So we finish the rhinorrhaphy, and then we finish resecting the tumor. So I think this is what I wanted. So tumor is finally resected. So this is a challenging case that I wanted to show. So this is the tumor removed. And thank you very much, Anup, again for this invitation. It was a great honor to participate. And I did learn a lot watching the lectures today.
Thank you very much, Dr. Rafael. I think very, very interesting case, technically challenging, and you did excellent job with robotic. So there's a question from the audience. In your experience, how do you select patients of carcinoma for robotic adrenalectomy? Do you have any fixed criteria? And how many patients have you converted in your experience to open?
So we haven't converted yet because we select patients like this one, like a small invasion of the upper pole of the kidney, no lymphadenopathy. These are the patients that we do robotically. If it has like a vena cava invasion, kidney hilum invasion, or lymphadenopathy, we usually do it open. We think it is still the best approach. So because we are selecting our patients, we haven't converted any adrenal carcinoma yet. But I mean, I wanted to show the literature because this is a challenging case, and we shouldn't offer a robotic approach to every single adrenal carcinoma that we see in our daily consultation.
Thank you very much, Rafael. I think that's the message from our this session. We have to carefully select patients for robotic or laparoscopic approach. Not all patients are for the minimally invasive adrenal surgery. And Dr. Professor N.P. Gupta said, you select the patient and do no harm to the patient. I think that's the message from our this session. We move to the last and very important session, which is the panel discussion. And this will be moderated by Dr. Renal Kumar. And we have the panelists. So I invite the panelists, Dr. Hofner, Dr. George, Dr. Rafael, Professor N.P. Gupta, Dr. Sudhir Rawal, Dr. Yuvaraja, and Dr. Ganesh Bakshi. So please, Dr. Renal, you can take over now. And we have 30 minutes and we can finish in time. Thank you. Please unmute yourself, Dr. Renal.
1 second. Yeah, I have to get my. Can you see my presentation?
Yeah, I think
No, it is actually the other presentation.
it's showing screen sharing. Yeah, we can see now. Please make it full screen and you can continue now.
Can you see that? Yeah.
Yeah. Please make it full. Okay, thank you.
Okay. Yeah. Here we go. First case is an interesting case. This lady, 33-year-old female, was pregnant 7 weeks when she came to us. She was a diabetic, hypertensive, and was having difficulty in controlling hypertension. So the physician changed the medication, and finally they ended up with 4 drugs. And her BP was controlled, and there is something happening about that. Is there an issue with my slides?
No, we can see. I think there was some problem with the, the setting.
Okay.
So we can see the slides otherwise.
I'll just discuss probably. So, the ultrasound showed a renal mass in the hilum. I will discuss because I know that the slide is not coming up properly. Ultrasound showed a renal mass in the hilum, and they did an MRI because she was pregnant. There was a exophytic renal mass, and according to MRI, there was a renal artery stenosis that describes 2 entities. One is a renal mass, then there's a renal artery stenosis that can explain the hypertension. And so the physician did. There's some problem with the slides, I think, is it?
I think the setting is there's some problem in the setting. I think the slide setting is not okay, but you can, I think you can show the the CT or picture and you can discuss. I think.
The metanephrines and non-metanephrines were elevated, so it added one more problem. So I thought that we'll ask Rajiv, because he's our secretary. He can open the batting. He's a batsman, and whenever problems are there, we look on to our secretary. So Rajiv, are you there? Rajiv TPG.
You can ask some other person. Dr. Rajiv, there was some issue. Yeah.
Okay. Anand sir, is it? Dr. Anand?
Hello.
Anand sir, this is a pregnant lady who presented to us with uncontrolled hypertension. We already discussed. Then there's a diagnostic confusion because ultrasound showed a renal mass, MRI showed a renal mass plus renal artery stenosis, and the metanephrines are elevated in the biochemical evaluation. How to proceed, sir? That is the first issue we are facing. Hello, can you hear, sir? Anand sir? Dr. Anand Kumar, sir? Dr. Anand Kumar?
I think he's not there.
Okay. NP Gupta, sir, is it? Dr. NP Gupta? Sir, Gupta, sir?
Sir, you need to unmute yourself.
Okay, can you hear me?
Yes, sir, we can hear you.
Now you can ask me what question you want to ask me.
Sir, this is a pregnant lady coming with a diagnostic confusion. There are 3 issues in front of us. MRI showed ultrasound showed a renal mass in the hilum. MRI showed a renal mass plus a renal artery stenosis probably. And biochemical evaluation showed elevated metanephrines and normethanephrines. How to proceed? This is a pregnant lady, 7 weeks.
Yes. Now, we have not seen the MRI picture here. But
sir, this was from outside and I couldn't get the pictures.
Okay.
Only report was there.
See, I tell you one thing which I have learned in my life, and I have got some cases in my book also, which I have made the rare presentation of urology cases. So sometime upper polar tumor, it is very difficult to differentiate whether it is an adrenal tumor or it is a renal mass or
So it's in the renal hilum. It's in the renal hilum according to
even at the hilum. Just 1 minute,
Okay.
please.
Okay.
So we have also seen pheochromocytoma can be adrenal or it can be extra-adrenal. So
Okay.
this can be an extra-adrenal pheochromocytoma. Now, as far as the diagnosis is concerned, for a diagnosis of pheochromocytoma, it should be a biochemical diagnosis. It is not the radiology. Radiology is done to identify the location of the tumor, the anatomical location. So if it is catecholamines are high, and I'm sure you must have repeated or you must have done some other samples also to confirm whether it is pheochromocytoma. If it is so, then we have to treat it like a pheochromocytoma. Now the question comes what to do about this pregnancy. She is only 7 weeks pregnant. So I'd like to ask you one question. Is this the first child or she had
Second.
This is the
She's
second
child. 33-year-old lady.
one child. So I think so counseling has to be done with the patient. And if they agree, then we should go for termination of the pregnancy. Otherwise, the other option is to go for surgery. But there is a very high risk that after the anesthesia or surgery, she may abort. So we have to counsel the patient properly.
If you want to proceed with the surgery, will you wait for 12 weeks or will you just do it then itself?
No, if at the time of 7 weeks, high blood pressure. One thing more I want to add because I still remember one case, Dr. Mansingh time I have seen that patient had a pheochromocytoma and it looked like that there's a renal artery stenosis. So because of the spasm, it looks like a renal artery stenosis, whereas once that pheo was removed, the renal artery became normal. So that is, I want to add that what you are saying, she had a renal artery stenosis may just be a coincidence that you may be finding, but you have to confirm it later on whether really she had a renal artery stenosis or not. So what I am trying to say is the counseling of the patient is very important. If your blood pressure is well controlled, she like to wait, then we must wait. Otherwise, in the first trimester, the loss of the pregnancy is very high if you give anesthesia or doing the surgery because it's a major operation.
Yeah. Sir, you covered almost all the points I wanted to tell. Like pregnancy is very high risk. They should be aware of that. And we discussed with the patient and patient was ready for getting an abortion. So we proceeded with a CT. So we did an abortion and proceeded with a CECT, which is our favorable ILM, 2.6 into 2.2 centimeter. And CT wise, there is no issue with the vessel. The arterial phase does not show any. But thing is, it was closely approaching, even it was partially, they reported as encasement, but partially covering the renal artery. That was the situation. So you can see that there are renal artery, there is a clump in the hilum, there is a round mass. And this is actually multiple vessels are going around the vessel and this in the hilum. This is the situation. So Dr. Hofner, so we have a probably extra adrenal pheochromocytoma because metanephrines are elevated. And which approach you prefer? Because the tumor is exactly into the renal hilum, almost covered in with the vessels around. So which approach do you prefer to avoid a accidental nephrectomy? You prefer an open, or are you comfortable with the lap or robotic? Dr. Hofner, which will be your preferred approach? And if it is lap or robotic, retro or trans?
Personally, I do more trans-peritoneal approach than retro-peritoneal approach. And in this case, I think it's very important to control all the vessels before to do the dissection of the tumor. And for that, I prefer a transperitoneal approach to be sure that I can have a good dissection of the IVC and maybe to clamp the renal artery between the aorta and the IVC, if you have to do a dissection around that. And I prefer, in this case, to do by robots, like you can imagine for me.
Thank you, Joe Hopner. Actually, we went ahead with a retroperitoneal approach, but we changed we changed the approach to race approach, which actually we innovated following Leblanc, one of the French surgeon who was doing laparoscopically, that is extraperitoneal approach. The HPR came as adrenal paraganglioma, and there was no extension seen around the fat, and pass score they put as 1. And post-operatively, surprisingly, all the BP, everything was controlled. This is what I was telling. Actually, advantage for this approach is we are going obliquely into the renal area, so that we can split the vessels orientation, and in between the vessel we can go and take out the renal mass. We could finish the case without much difficulty. And even though I had done transperitoneally for one of the patient, I found that probably in this patient, I don't know in other patient, but this is very useful approach for area like that. But other cases I had done transperitoneally, as you had rightly told. So second case, so we will move on to second case. This patient actually had a hematuria 3 months back before we consulted us. Had hypertension and diabetes for 2 years. And ultrasound wise, there were bilateral renal masses. All were more than 6 centimeters in size, and there was an adrenal mass in the ultrasound. We did a CCT of abdomen. Those bilateral renal mass, sorry for not mentioning bilateral renal mass. And left side renal mass was more than 6 centimeters with sinus involvement. His serum, metanephrine was elevated. Normethanephrine was elevated, and he was started on that is prazosin by endocrinologist. That is our preferred method of control of hypertension in our setup, at least. Like Raghavan was discussing phenoxy with him, but thing is, we used to have prazosin as along with the calcium channel blockers as the preferred method of controlling or preparing PO patients. So this is the scenario. So we have done a MIBG scan following that. Because I was not having a CT picture to reduce number of slides, I just put the MIBGs. So at this point, NP Gupta sir, regarding the MIBG scan, do you routinely go for MIBG scan in PO, or is there any selection criteria for requesting for MIBG? In which scenario you will ask for MIBG scan in a PO?
See, I don't advise routinely in every case MIBG scan.
Okay.
Number one. Number two, in selected cases, for example, as you have shown that case of extra adrenal pheochromocytoma, because there can be many more, not only one. So that is one situation. Or if we have a suspicion for any other lesion, like a spinal cord tumor or somewhere else in the body, then we say that MIBG scan should be done. The third thing is that after the surgery, if there is a blood pressure is persisting, we might have missed some tumor, and that is the ideal situation to do a MIBG scan. In presence of the active large tumor, if you do MIBG scan, you will miss the other small tumor. So better is it may not be of any use if there is a clear-cut diagnosis,
Okay. So if you are suspecting a malignant PO, will you do a MIBG in the first round, or you will remove the pheochroma lesion and then go for MIBG as a second setting?
I think so.
Like large POs.
No, in case of large POs, and if I am confident that I am dealing only with one adrenal, then I will say better to do adrenalectomy first and then go for
Okay.
the MIBG scan.
Great, sir. You have discussed this thing. So basically, if you are expecting all the scenarios where we are expecting multiple focus of pheochromocytoma, we go for MIBG. Otherwise, we will do the surgery and follow up and see if the symptoms and parameters are reducing, like hypertension and the status of markers are reducing. Then we will go ahead with the MIBG. Yeah. Yuvraj, what do you think about the diagnosis in this patient and how are you going to manage? There is a pheochromocytoma, there is bilateral tumors, 1 centimeter, one side it is a, you can see that in the CT, it is almost going into the sinus and almost, involving the sinus and involving an almost good part of the kidney. On the opposite side, there's a tumor and there's a pheo. In this scenario, what is your diagnosis? And how are you going to manage this patient?
Yeah, Ginil, can you hear me?
Yeah, we can hear you.
Yeah. So I think diagnosis is looks like VHL. So he has got multiple tumors.
Perfect.
And he has adrenal tumor. So in this situation, so as Dr. N.P. Gupta told, we don't do MIBG, but we do DOTA scan. So that is more sensitive and specific, and it identifies all the lesions. So that's what we commonly do it, because we have a MDT with endocrinology. They prefer DOTA scan over MIBG scan. So diagnosis is quite simple. So management, we know that. So we have to remove this tumor as well as the kidney tumors. So we have to prioritize. So I think we should go to the right side first and do partial nephrectomy along with adrenalectomy. So that should do well, because the tumor has to be removed. Adrenal tumor becomes important. Then I would tackle the left side later on. So that's what I would do.
Are you going to right side because there is adrenal tumor, or you routinely go for? If there is a renal mass alone, you would have gone for probably.
Correct. So that we can prioritize. But here in this case, if I do in the left partial or total nephrectomy, so in the patient may develop either in the intra or post-operative, hypertension or these changes. So I would prefer to tackle the adrenal tumor as well as the kidney tumor at the same time. So I think I would prefer the right side first, and then in 1 or 2 weeks we can go to the other side.
Perfect, Yuvraj. That is exactly what we did. So diagnosis in this patient was one Hippolyto syndrome. This is actually a syndrome where multiple renal tumor, renal cyst, PO, then pancreatic cyst, all the different features we know. So we have to check for thyroid lesions. This was a one Hippolyto case, and we did first right partial nephrectomy and right adrenalectomy, followed by left lap radical nephrectomy, because obviously it was completely involving the sinus. As Yuvraj rightly told, why didn't we go for right radical nephrectomy first is obvious. When there's a pheo, that is a critical thing, is a life-threatening issue we have to tackle. And along with that, we can tackle the renal mass partial. And once we have got opposite kidney is functioning well, so the post-operative will be smooth, then we can go ahead with the right radical. That is exactly what we have done. And adrenal mass was 3 centimeter. Pass score was 1. Yuvraj, is pass score, do you follow regularly? Is it very important?
Ginil, before that, how did you do the right side? You didn't mention that.
Yeah, so we did a open. I know that because when bilateral, I usually go for non-clamp open partial. That is my favorite, because I'm concerned about the clamping of that kidney, because it is going to be a single kidney. So we did non-clamp right partial open along with the adrenalectomy, followed by a laparatory. Probably robot also is a equal option. You would have preferred a robot, but I prefer. But it is individual preference, that is all. And among the other faculty, how do you prefer? Will you prefer a robotic or open approach, Dr. Hoffner or Casso or Colo? Which one you prefer, sir? A robotic or open in this patient? Dr. Casso?
I mean, I always try to do robotic first.
Okay.
I think, for example, earlier it was presented that, in certain cases we have to be careful, and that open is suggested as preferable in some cases with carcinomas and such. But I find that I always have better visibility when I'm doing something robotically. I can always really amplify the view and see things quite clearly. And, it's not that difficult to switch
Retro
to an
or
open procedure.
retro or trans?
Both ways.
I know that you are a retro man.
I do enjoy retroperitoneal quite a bit, but again, I think a lot of this boils down to what your experience is,
individual preference.
Because the scissor cuts the same tissue, whether it's open or robotically or laparoscopically or whatever it does. It's the person holding the scissor and cutting that's the biggest deciding factor.
Okay, great. Dr. Hoffner, will you again go for a robotic approach for this patient, or because it's a bilateral renal mass plus an endocrine? Hello. Probably.
I think you can ask Dr. Anup Kumar or Dr. Ganesh. Yeah.
Dr. Anand sir is could not join, isn't?
No, I'm there. I'm there.
Okay, sir. Yeah, okay, sir. So this is actually an interesting case, sir. Right?
I would have taken the same what you Raja told you, and you did it.
Robotic. Yeah.
But right side, it's a tumor which can safely be removed within 15-20 minutes with the robot without any harmful effect, and adrenal can be taken care of. And left, I would have done with the laparoscopic radical nephrectomy, and right would have done with the robot, both the things.
Okay. Okay, sir. We'll. So this is the finding. SPR was pass one. This pass score. Are you very? So Anand sir, I'll ask sir. Pass score and V score. All these things you follow up critically, or just you just neglect those things?
Not routinely.
So in a small mass, this pass score, is it important, sir? Pass 1, pass 4, pass 5, because chance of malignancy.
See that actually one important aspect of adrenal malignancy is that the surrounding tissue involvement. Actually, most pathologists also make the diagnosis if the surrounding tissue is invaded apart from the other histopathological features. So that is the more important aspect. And so routinely we don't follow it, but yes.
Okay. So there are some criteria like V score and pass score. Pass score more than 4 is more suggestive of a malignancy. That is how they grade the system. And V score, that is in adrenocortical carcinoma, not in PO. V score more than 3 or above is suggestive of adrenocortical carcinoma. This is how pathologists grade the system for chance of malignancy. So we'll move on to next case. It's interesting. A young lady came with amenorrhea 5 years, history of avascular necrosis of femur, and history of actually bone grafting for bone compression and spinal surgery and right shoulder. Different issues in the past. Is a florid case of Cushing syndrome from age of childhood, like 16 years. He's having hypertension, Cushingoid, classical features of Cushingoid, ultrasound is normal. So I'll straight away move on to the biochemistry. Biochemistry, this is the findings, sir. So I will again discuss with Anand sir about this because you are from SDPG, and SDPG is one place where we find a lot of federal mass is endocrine surgery is very active. Sir, about this patient, where will you put this patient with this biochemical? Cortisol, high, thyroid, TSH was done, but this overnight testosterone suppression test is again high. ACTH is low.
It's just like a Cushing syndrome.
Okay, sir. And ACTH dependent or independent? That is the next question.
It is not suppressed, so it is not dependent.
So it is a ACTH independent. That is because ACTH is not increased. It is not because of the stimulation from the center. It is actually adrenal. Both the adrenals are secreting. That is a finding because ACTH is not the factor because of which the adrenals are secreting cortisols. So, and it is not suppressed. So it is not. We are confirming that it is Cushing's. So this is the finding. So it's a ACTH independent. And curiously, you can see that the adrenal mass is very small, and you can see there is small lipid-rich adenoma. There is 74% washout, and left again small adenoma. There is washout of 34%. So I'll ask Ganesh Bakshi because he is from Onco Institute and he will be very familiar with the washouts. So Ganesh, are you there?
Yeah, Vinil, I'm there.
So, what is the clinical implication of this washouts in
So
CT?
usually, if we have homogeneous adrenal nodules, like what you say, or which cannot be otherwise associated with elevated metanephrines or other levels, then a dedicated adrenal washout CT protocol is done. So what we do is we contrast enhanced scan at a delay of 60-90 seconds and another at a delay of 15 minutes. So a relative washout and an absolute washout, yeah, as you have put, both suggest adrenal adenoma, and there are a few pitfalls in it. One is a hypervascular, something like a FEO might show washout, but it will get caught with the metanephrines. A hypervascular renal met also might show washout, but it will have other renal cell carcinoma somewhere. And there is another small thing like
do you give a lot of importance for this washout, or just depends more on his?
Not a lot of importance, but if we get a homogeneous adrenal mass, say about 2-3 centimeters, and we don't fit it anywhere, it's not associated with any raised values anywhere, then we focus on this. And sometimes we do get references from the breast cancer and gynecological cancers who the females have these adenomas. So sometimes when we are in a dilemma, we do the washout protocol.
Don't much depend on the washout study.
So sometimes it's very diagnostic, like of an adenoma, and we leave and we would monitor. And whenever we are doubtful, then we'll have to go for other things, like Dr. Yuvraj had suggested scans and all. And if still not, then last option, very rarely we do a biopsy.
George, I wanted to ask you a question about the plan, but thing is I accidentally put it there. So, so you also prefer to have a bilateral adrenalectomy for this one, George?
Yeah, I think a bilateral adrenalectomy would be quite reasonable, yeah. So I can tell you, I can also talk to you about what approach I would use.
Yeah. Which approach will you prefer?
So
definitely not, is it?
Well, the interesting thing about this is this opens up, I guess, another approach that I do in very select cases, because these are smaller adrenal glands, and you're not worried so much about malignancy. So this would even be a good single site laparoscopic with a patient supine, tilting them one direction, doing one adrenal, tilting them the other direction, doing the other adrenal.
You mean prone or?
I'm sorry, yeah, with face up. Yeah. So
yeah.
And you could do something even like a natural orifice through the umbilicus, get both adrenals out without much issue. Yeah.
So it can be transpectoral or retropectoral. Both you can manage with a single. Yeah. Okay. So I'm interested about this approach. Had you ever done this? Yeah. So prone position from behind. We had done a few bilateral adrenals in this position because it is. Sometimes anesthesia doctors will not be very happy about this position, but you will be discussing about this only, is it? Posterior approach.
Right.
So posterior approach is a convenient when we are having a bilateral adrenalectomy plan. So this is one point I wanted to highlight. You can do it laparoscopically or robotically. I prefer laparoscopically because robotic sometimes it hits the bum very much when we are dissecting. That is one issue I faced when I did a robotic of this approach. So this patient came as adrenacortical hyperplasia of the adrenal disease. nodal hyperplasia. And on follow-up, she is very much controlled with the hypertension, diabetes, everything is controlled. So if there is time,
I think
yeah, we will stop.
You have to wind up.
Okay.
Yeah, sorry.
Okay then. Thank you very much.
So I think thank you very much, Dr. Janil. It was excellent case presentation, discussion. I'd like to thank all panelists. I think Dr. Anup Kumar want to say something.
Yeah, Ginil, I wanted to say this is a very, like when you have a bilateral small tumors, if you just put the 3 ports in the midline, and you can do both the case, you just have to change the position.
Laparoscopically.
So that you don't have to change the port. So whenever we do bilateral, we just sometimes might have to put a very small port just for retraction, but otherwise 3 midline port, you can do both the positions.
Oh, great, sir. Yeah.
Okay, so
thank you very much.
I want to thank all our international faculties, national faculties, Professor N.P. Gupta sir, Dr. Anant Kumar sir, Dr. Rajiv TP, and all our esteemed faculties who have joined us. And we are happy to inform more than 1,000 urologists. They have watched this program live on various portals from different countries. And that makes it a huge success because of all your contribution. I want to thank also all delegates who are watching this program live. And I think this was a really academic feast for all our youngsters. And Professor N.P. Gupta has said, I think urologists should continue doing adrenalectomies, whether it's minimally invasive or open, they have to continue. That's the message we have learned from today's exercise. So I think before I wind up, I will request if Professor N.P. Gupta is there, he can give his final concluding remark. Professor Gupta, sir. So please unmute yourself. Unmute yourself, sir.
So I like to thank all the speakers for their presentation. They have done the excellent job, and we have covered most of the surgical procedures for the adrenal gland. And one thing has become very clear, that minimal approach by laparoscopy or robotics, depending upon the experience of the surgeon and the facility available to him, I think so that is the best way to do the adrenal surgery as far as possible. However, in rare situation or large tumor or something, one can go ahead with the open. But I think so in most of the cases now, minimal invasive surgery should be the approach. And that is the one area where we can certainly, as a urologist, score over the endocrine surgeons, because they may not be having that experience of the robotic or, like that. So with this, I think so this is a good session. We learned a lot, and thanks to all the speakers.
Thank you very much, sir. I want to thank our knowledge partner, Intuitive, also for this exercise, for helping us in this program. And a special thanks to our international faculties again, Dr. George Casso, Dr. Hoffner, and Dr. Raphael for joining us. Thank you very much, sir. Have a good night. Please stay safe and take all precautions. Thank you.